Welcome, and thank you for coming. It's our second Maac meeting of the year. We're very excited to have all of you, but we're very excited about the agenda today. You know, we teased it out at the end of our last Maac session, but today's focus is all around innovation. Innovation in terms of contracting, innovation in terms of use of technology, and innovation in the way that our products are adapting that technology for use in the market for your employees and their family members to better engage with their health plan and better interact with their health plan and better interact with their providers. So because the agenda is so bountiful today, we did decide to extend our meeting a little bit. You saw it in the agenda. We're going until 12:30 today. I will commit, as I've committed in the past, to getting us out early, so we will not be leaving at 12:30 today. But you will be leaving, among other things, with a box lunch, because we didn't want to take you to the lunch hour without leaving you with food. Hope you've enjoyed the breakfast this morning, but don't fill up too much because you're leaving with lunch. So we've extended to 12:30. There will also be a small break in between today because we're going a little bit longer. We will have a bio break. Again, for any folks that feel the need, don't feel like you're chained to your chair. If you need to leave, please leave. So again, I think the most interesting piece, and when you think about the biggest lever that you can pull as a plan sponsor, it's all around the interaction with providers and the influence that providers have on the market. The most intricate plan design, the best tools in the world, the best education and information that you put in the hands of your members, your employees, and their family members. 80% of that decision is still made by the provider. Because when the provider says, you need this, and this is where you need it, the likeliness of that member stepping up and having an influence in that decision-making process is slim to none. And so pulling that lever and pulling that lever hard is the biggest thing that we can do as a plan, as your partner, working with those providers and understanding that local network, that local knowledge, that local dynamic of the provider community, and the local geography, and understanding that in some markets, you can travel 20 miles and it looks like you've entered another country. And in other markets, you can drive 30 miles, 40 miles, and be in another state like ours. And that dynamic and that knowledge and that understanding of the provider community is critical to understanding how to put payment models in place that will make a difference and will drive practice pattern change among the provider community. It's why we're so excited to feature today not just a Massachusetts message and not just a global global national message, but really a message that starts focusing where many of you as employers have employees and where many of you as employers have your employees travel. And so we've reached out to our friends in North Carolina and HCSC, who represents Illinois, Texas, New Mexico, Oklahoma, and now Montana. Did I do a good job there? Yeah. 5 states. And Rhode Island, where we have a ton of our membership residing, and markets that are so different from Massachusetts and from each other, but in many respects similar. And understanding how that dynamic really plays out in the market. I'm also really excited to have with us today a very non-blue and independent view of payment reform contracts, and someone that has spent an exorbitant amount of time studying these contracts, working with health plans and the government across the country and evaluating these payment models, evaluating health plans, and working with hospitals to identify the most efficient way to deliver care. And so leading off today's agenda, I'd like to introduce Michael Chernew. I won't spend a ton of time going through bios. You have them in front of you. But among other things, Dr. Chernew has been a lead author and independent evaluator of our AQC contract in Massachusetts, payment models across the country, Medicare, and really understanding how this dynamic and how the market really works here. He has some data-driven and published studies around what works and what doesn't work. Certainly, we have, as an independent evaluator, have our times where we may not necessarily agree at all times. But I think what's really unique about what Dr. Chernu brings to the table is that independent view. Because no matter what we do, the data can't lie. And I think it's really interesting to see and hear from Dr. Chernu around what the market's doing. Following Dr. Chernu, we'll also be inviting our guests from our sister plans up, as well as Dana Safran from Blue Cross Blue Shield in Massachusetts, to talk about their local experience, their contracting models, and what has worked in their market and the unique dynamic of their market, but also looking into the future and what's going to happen down the line in their particular markets. So in addition to Dr. Chernu, I'd like to welcome Eric Helms, Sherry McClure, Troy Page, and Dana Safran following Dr. Chernu's keynote address. So with that, Dr. Chernu, welcome, and thank you for coming to Maac.
Yeah. Thank you. Is there a clicker for the slides? Perfect. So I'm thrilled to be here. A few quick things. I'm used to seminar-style things, so that means being interrupted in the middle. I have a hard time just sitting and listening to someone talk. So feel free to interrupt any questions you want as I speak. I am going to talk largely about money. I'm an economist, so that might not be surprising. There'll be a few things I say about quality and such, but for the most part, I don't mean to give you the impression that money is all that matters. It's just all I really have time to focus on. So let me, with that, just jump in. So here are my slides. So a few things which I think you know. I should tell you one thing that wasn't said. It may not even be in my bio because it's not a thing. I chair the Harvard Benefits Committee. So I spent a lot of time at Harvard University thinking about some of these related issues. And the one thing that does seem clear is as healthcare spending rises, it puts an enormous amount of pressure on other aspects of spending and on wages and how to manage it. So I mean, for my broad policy talk, I have a version of the slide for the federal government. I have a Medicaid version of this slide. But I thought for here, just the private sector version is fine, which is healthcare spending historically has grown very rapidly, and that's put a lot of pressure on other aspects of competition in the business overall. And certainly, although everyone thinks Harvard has a gazillion dollars, maybe they do, but believe me, they don't feel that way if you've been reading the papers. Anyhow, so I'm going to jump into a lot of innovation and benefit design, but I want to start with something that I've been both doing work in and I think ends up being important. Healthcare spending growth has slowed over the course of the recession that we just came through. So there's a million slides like this, but basically healthcare spending growth was running, 2% a year, and it dropped down to under 1% a year. So healthcare spending wasn't going down. Its rate of rise was going up more slowly. So we were having more spending, which is why I'm an economist and not an English professor. But in any case, so the issue is, will that continue? Have we basically solved the problem and reached some sort of sustainable spending level? And before I talk about innovation, I think it's important to understand, well, what do we think is going to happen sort of in absence? And so two quick questions. What caused the spending slowdown and will it persist? So you should know, I am in fact a Harvard professor, but I have no idea what's going to happen. It's much easier to look backwards than it is to look forwards. So I'm going to say first something about what I think happened, and then maybe a little bit about speculating what will go forward. So why I believe the spending slowdown was not simply due to the recession. It started before the recession. If you look at the rate of spending growth, it was slowing down prior to actually when the recession hit. It affected populations not as strongly affected by the recession. So if you look at people that maintained strong, good coverage, spending was slowing down for those people who did not lose their job. They did not get put in higher deductible health plans or other various things. There was also a slowdown. There was a slowdown in spending in Medicare. So it turns out Medicare beneficiaries, they're not as affected by the recession as non-Medicare beneficiaries. They don't have to worry about taking time off work by and large. Their benefit generosity is basically based on the benefits they had when they retired. But still you saw a big slowdown in spending amongst Medicare people. And if you look at why spending was dropping, it was dropping from very specific clinical reasons. A good example would be imaging and radiation benefit management stuff. No one believes as the economy booms, we're going to get rid of some of these sort of controls on spending. So my view is spending was slowing down in part because the system was doing various things. Why the system was doing those things is a separate question, but it was really something that was happening because of changes in the system. We've seen them in the past. So just because it did slow down for that reason doesn't mean the slowdown won't continue. There's a lot of challenges, one-time factors. So there were patent expirations. No one believes the patent expirations were due to the recession, right? But they happened to expire during the recession. So there's some big blockbuster drugs that were coming off patent. But it's not inevitable. The provider system can respond by trying to get more money. And of course, there's a whole bunch of new drugs. If you followed Sovaldi, the Hep C drugs are the ones that people commonly talk about. But there's cancer drugs. There's a lot of drugs in a lot of areas. And so the pressure to spend may well come back. The key point, and we saw in the 90s when healthcare spending slowed, in fact, it rebounded again. The most important message that I think I would give about this entire topic is the spending slowdown is a choice. It's not fate. I get asked by reporters all the time, will spending growth continue to stay low? And the problem with that question is it's asked as if it's fate. When really the answer is, well, that depends on what we do. It depends what the insurers do. It depends what the providers do. It depends what policymakers do. So there's a question, if we want to continue to have a slowdown in healthcare spending growth, it really is what we do that matters. If you look, there's been some evidence of a bump up in 2014. Still lower than historically, so this is nominal, the other numbers were real. But in any case, you can see some spending growth due to a range of things. Prescription drugs gets a lot of the attention. The big thing is actually not prescription drugs, because prescription drugs is a rapidly growing spending category, but on top of a small relative share. Most of the spending rebound that people look at nationally is healthcare services. What they're missing from numbers like this is we've insured a whole lot new. This is a sort of a national number. We've expanded coverage to a whole bunch of new people. So that's overall, of course, you're going to expect more utilization when you've brought as many people as we had into the insurance market. It's not yet clear. We'll have to wait to see what's happening on a per capita basis, holding benefit design constant and stuff like that. I haven't seen that data. The people actually here may well know. I just don't have access to data as quickly as the people here do. So my basic view of this whole thing is healthcare spending slowed. We know that it's slowed. There's some evidence that the slowdown may be nearing an end. What happens in the future should not be thought of as, well, let's just ride this thing out. It really is about the choices that folks make. So the main part of my talk, I'll call loosely solutions, but sort of what are we going to do? I think if I were a better market, I would call it innovations or some other better. So I'm going to mention 4 things. I'm really going to focus just on 2. So payment reform is, I'm going to spend much of my talk on payment reform. Consumer strategies is my broad summary for a whole bunch of benefit design, consumer engagement type strategies that a lot of folks are doing. I'll say a little bit about that. Competition and managed care. So I'm an economist. I'm a fan of competition. I'm a fan of these types of things. It turns out that, and again, in a room with a lot of folks in blues, when insurers are trying to figure out how to hold premiums low, the main place you want to manage costs is actually the delivery system. Right? That's where the biggest cost is. So if you're going to figure out, as an insurer, we're competing with other insurers, what are we going to do? Your answers are going to be payment reform or some sort of consumer engagement stuff. So I'm not going to talk a lot about, again, I'm a fan of competition amongst insurers and hospitals for that matter. But the solution the competition gives you is to go back to the delivery system, putting you back into payment reform and benefit design. So there's a lot of folks, myself included, that have done work in changing organization of medical practice, medical homes, for example, integrated delivery systems. My personal view is as we go down this journey as a country, there will be changes in the way the delivery system is organized, but those changes themselves, without changing any other incentives, will not actually reduce spending and get us better quality. And I'm not completely sure who's in the audience, so I'm going to say something that might get me in trouble. There are some wonderfully large, unnamed systems that do terrific things. Many of my colleagues work for those systems here in Massachusetts. I have nothing bad to say about them since, I'm so closely related to them. They are integrated. They have great IT. They have wonderful primary care in a whole variety of ways. I've gone there for care in a bunch of ways. I have nothing bad to say about this unnamed place. The point is not that it's just not cheap. That's really the point. It turns out that if you have a big integrated large delivery system doing everything that's right, but they have incentives to spend a lot of money, it turns out they'll spend a lot of money. It's the incentives that go around those new transformed delivery systems that really matter. So I'm not going to talk a lot about organization of medical practice. And I guess usually, particularly with the students, I don't get through this talk without saying something about wellness, because there's a large number of people that think we're spending more money because we're just so much less healthy. We eat worse. And, I got my little Fitbit thing on to make sure that I walk enough. But it is true that we are less healthy. And just to be clear, I'm all for health. So, eat better, walk more, whatever. But it turns out that there's no way we're going to solve the basic fiscal problems we face in this country through fundamentally just wellness. I have not yet seen I've seen wellness programs that I think work better than others, but I have not yet seen the wellness program where I would say, you know what, we don't really have to do this health policy change or this health training. All we need to do is just wellness, right? There's not enough money there. I don't think they have a big enough effect. So I'm not going to talk a lot about wellness. And it turns out that, in fact, the statement that we're spending a lot more because we're just less healthy is actually substantively not true. We're spending a little bit more because we're less healthy. But that's not the big issue. And again, let me be clear. We have a wellness program at Harvard. I'm all for wellness. I think it's important, but the amount of money, if that's your basic problem, is not there. So let me say something about payment reform. So it turns out one way to pay less is to pay less. And I don't know why this required the amount of effort for people to really understand. It seemed obvious. And you see a lot of this in federal policy in general. Just if you could pay less to providers or to health plans, you can save money. And a fair bit of the Affordable Care Act was financed by just paying less. They wrote into the law, we will pay physicians less, we will pay hospitals. Actually, they didn't do physicians because they were at the time governed by the SGR, but they wrote in they would pay hospitals less and a bunch of other people less through this thing called the productivity adjustments in the Affordable Care Act. So they pay less, and they reduce the amount that they pay plans, particularly Medicare Advantage plans. So there's a lot to be done on paying less, and of course the government can do that a little more easily than private sector plans because they actually just control the prices. No one I know is excited about the pay less strategy, largely for two reasons. One of them is it doesn't deal with fragmentation issues, so the payment system itself has a whole lot of inefficiencies and coding problems and stuff. And two, it's not clear how far you can ride that horse. It's not clear. You just can't simply pay less and expect to get the same level of access and the same level of care the way the system works. So the goal has broadly been to pay differently, which is sort of synonymous with moving away from fee-for-service payment. And there's two ways to do that. I'm going to largely talk about patient bundles, global budgets, things like that, where you take give a fixed amount of money or a budget. Is usually the way it works for a population of people. You see that, for example, in the accountable care organizations, which I'll discuss. But also episode bundles, which are also important ways of paying, where you pick a hip or a knee or some other episode and you pay a fixed amount for that. And I'll say some more about those programs. Again, fee reductions remain popular, certainly at the policy level. There's a lot of ideas of, I was the vice chair of something called MedPAC, which was the Medicare Payment Advisory Commission that advises Congress on Medicare. And again, the government could deal with the pay less strategy a lot better than I think private sector organizations can because of the nature of the government's ability to just set what the fees are. But the fee reductions don't affect many of the underlying problems, so people are moving away from them towards reforming payments. So let me talk about a wide range of strategies. So there's global payment models. In Medicare, they're largely thought of as the accountable care organizations, and I'm happy to talk more about them if you want, but essentially they're a global budget type model. There's different variants. The new regulations just dropped for them going forward. In Oregon, there's something called CCOs, Coordinated Care Organizations. That's a Medicaid. So the theme is sort of federal, state, private. So ACOs are federal, Oregon is state, the CCOs, and you'll see other types of global payment models, I think in Medicaid and a lot of places like Illinois going forward. And AQC is probably the most prominent global payment model in the private sector. That's here in Massachusetts, Blue Cross Blue Shield's Alternative Quality Contract, which I'm going to discuss a bit. There's episode payment bundles. So again, federally, they have the Bundled Payment for Care Initiative, Care Improvement, which is BPCI. Arkansas has built a system around bundled payments. Blue Cross Blue New Jersey has a bundled payment, an episode payment model. Medical home-based models. So again, the federal government has the Comprehensive Primary Care Initiative. North Carolina has a version, something called CCNC. There's someone here from North Carolina, so you may be able to talk about CCNC if you consider it we're actually doing an evaluation of CCNC. That's a separate story. And Care First, which I just picked things we're evaluating actually. Care First is Blue's plan in the DC Maryland, Virginia area, they have a medical home-based model. Just to be clear, most of the medical home-based models include some payment component to them in various ways. They're not simply medical home, and in fact, I would argue the key thing around the medical home is how you build in the payment models and the incentives around them. But in any case, there's a wide range of things. And I will say, having gone to a lot of places, many foundations, so we get funding from foundations, they will often say, well, let's go out and figure out what works, and then we can go make sure everybody does whatever works. And the problem is, of course, every place is different in a whole variety of ways. So if you go, for example, to Arkansas and say, well, I was here, and I'm going to present you some data in a minute about the alternative quality contract and the results, which I think were very good here in Massachusetts, and you go, well, why didn't you do the alternative quality contract? Weren't you reading my work? And they say, first, we weren't reading your work. Secondly, even if we weren't reading your work, we're just a different place. It's harder to figure out how to do that. Now, I do think, just to be clear, I think some of that is true. I very much believe some of that is true. Some of that I also believe is a little bit of a cop-out for a whole variety of reasons. And there's a range of organizations. So Geisinger, if you follow Geisinger in Pennsylvania, they have a model now they're trying to diffuse it. There's a lot of folks trying to figure out how to take what they've learned, because most of these places do learn things, and figure out what parts can be kept and what parts can't as they move to other places. But the one thing that does seem to be clear is you do have to take whatever it is you're doing and tailor it to the place where you are. So there are lessons that I think are common, but there are also environmental factors that means everything's going to be a little bit different, and a lot of this is going on. So regarding ACOs, and this is data from Levitt Partners, and they use, so the Medicare is in the blue, but there's also a lot of private ACOs, and there has been a movement, and I don't know how many, those of you at National Accounts can look across the different areas where you serve, and certainly I know the blues do this. There's a whole range of payment models, and there's an ongoing semantic debate that academics love about what counts or what doesn't count in this version of what an ACO is. So this is using the Levitt Partners definitions, which involve the globalness of payment and the amount of risk that organizations are bearing, sometimes only upside risk. But the broader point is, you should both see the trend is up and understand that whenever you see the axis is numbers, you realize they're not giving you percentages. So it looks a lot bigger. There's a lot of places that aren't yet in ACOs. But it is growing, and I do think there's a lot of interest across. I sit on a board for the American Hospital Association, and all the organizations are trying to figure out how to get in to these broader types of models to bear risk. And what I say when I talk to provider organizations is, when money gets tight, and money will get tight, you want to control the money. And these types of contracting models allow the organizations to control more of the money and capture some of the efficiencies if there are efficiencies to be captured. And so I think increasingly organizations, and again, not all of them, but there are more and more organizations that are interested in these types of models if, again, they can get the specifics to work. So the basic features of all of these things. They're all based on transferring some type of risk to providers. Almost always they're built off of some fee-for-service chassis. So the money is flowing throughout the system using the same fee-for-service chassis, but there's some budget or some target that the organization faces, and the organization is at risk if they spend more in some cases. They certainly get to share the savings if they spend less. In some cases they have to pay more. They're at risk if they pay above the budget. And they're almost all primary care focused in the sense that the money, the residual claimant, is typically the organization that employs the primary care physician. So for example, in Medicare's ACO program, the way you get assigned to an organization is by the place where you're getting the majority of your primary care. Almost all of them include some pay-for-performance or some quality bonus system, so there's an enormous amount. The work that Daily Blue Cross has done has been very comprehensive in that regard. One thing that, so I knew about the first two when I started this journey. One thing that I really didn't understand, because I'm not that close to the delivery system, is the importance of data support. And the one thing that's clear, there's just an enormous amount of data support that's required. The organizations tend not to know how to succeed under these rules. So economists, in the typical joke, assume a can opener. That's the punchline of a joke you probably haven't heard. But they often assume some solution. And if you just put the incentives in place, the system will just transform and we'll live in nirvana. It turns out that's not true. And the underlying data support structures matter an enormous amount and vary. And many of the organizations that take these things on, they often start with the data. How are we going to manage the information flows to do this? And then there's complicated assignment rules. So in the AQC, the beneficiary picks the primary care physician, so you know where they are, although we can talk about how to apply that to PPOs later. Dana will be on the panel, you can ask her. In Medicare, it's been much harder. They have an attribution set of rules, and there's all kinds of issues with the way they do attribution rules. One thing that I do think is true is the federal government tries to put these rules in that work everywhere, which is much harder than trying to put rules in that work in very specific places. In Arkansas, when they do bundled payment models, it's a lot easier because episodes are easier to attribute. You can attribute the childbirth to the OBG. You can attribute the surgery to the surgeon. It's a lot easier to do that type of attribution than a person attribution model where the person may be seeking care over time, although, again, you have to look at the data to see how big a problem that is. But this is how these basic models work.
Mike, can I ask a quick question?
Yeah.
So when you look at data support and when you look at kind of the provider's ability to take on this risk, the concept of volume, really comes into play. You talked about the role of the feds at the state level and then individual insurers, but you're taking smaller and smaller pieces of the pie as you cut down. What is that kind of critical mass or volume that you need in order for the health plan to take on these contracts, but also for the providers to take on it?
So almost all of them, I'm going to talk about volume from the provider point of view. Almost all of these have a version of this where the provider has to have a minimum level of people, and usually the number would be 5,000. So the organization has to have at least 5,000 patients from whoever, the payer has to have 5,000 patients assigned to the organization to make it stable enough. And there's some argument that the 5,000 is too small, so the pioneers, they put you at 15,000, for example. So there's a question for how smaller groups can manage. What happens is, so in places here where there's some big delivery systems that kind of works naturally, in places like Arkansas, for example, where there's smaller groups, Maryland Care First, there's smaller groups, there's sort of one or two strategies. One is you don't do global, you do something that, so I will tell you, I prefer global. Just if you were to ask me, I spent yesterday evening with someone from the UK and how they do it. There's an enormous amount of appeal to global type models in a whole variety of ways. It gets around certain problems, it allows for accountability to work, it allows the efficiency to work better. I think bundled models can only capture certain numbers of things. You have these very complicated issues. Well, the person has diabetes and they had a heart attack. How does these concurrent episodes are going around? But global's harder to do. So one thing, so in Arkansas, they go to bundle, not because they don't like global, but the size issue was a problem. The other thing they do, which they do, for example, in Maryland, is they try and have these virtual linked groups in a range of ways. In fact, they're doing that in the UK as well. And that requires, it remains to be seen how well these sort of virtually linked groups that can get you to 5,000 or 15,000 can work together, because the delivery system itself is now independent folks. And so how you deal with what we would call, a colleague of mine, Bruce Landon, would call the keeping score underneath ends up being important. So one thing that I guess many of you will say, and so again, I basically just talking cliches, I actually have a few in a minute. It turns out there's no substitute for good management. The actual management for how you're doing these things, apart from sort of the academic, this is how it will work, the actual execution ends up mattering an enormous amount. That's harder to do in a virtually bunch set of panels than it is in an integrated delivery system. There's other problems with big integrated delivery systems. So if I were going to take the other side, economists always take the other side. If I were going to take the other side, I would say the problem with the big organizations is in the price negotiations, they have more leverage. So the other issue that arises here that ends up being important is you need to have enough price leverage to offset the provider. The payer price leverage has to be able to offset the provider price leverage. If you have, and we've argued this about insurance competition, and I said I'm a big fan of insurance competition, but the one problem is if you have insurers competing and providers that are monopolies, you're going to have a basic problem because the providers are going to be able to capture just the prices. So you need to have, there's a price component of this that actually transcends the actual health set of things, which for the federal government they don't worry about very much. Like, it doesn't matter if all the hospitals in the country became a monopoly for Medicare. They would still say, well, here's the price. But that's not how it works outside of the federal system. So volume matters for a bunch of risk and technical reasons. There's also infrastructure reasons. The other thing I would say, which is certainly true here to some extent in Massachusetts, although not as quickly as I would like, which is a little disappointing, is organizations that begin to move in this direction like to move in this direction for as much of their business as they can. Because it's very hard for the organization if they're getting paid part fee for service, part global payment. So you'll see, for example, Partners will be my example. They joined the AQC, they became a pioneer ACO, they bought a health plan to try, as an organization you want some harmony of incentives that you face in many delivery system organizations like the hospitals at the AHA complain that they're, half of them, they have one foot in the canoe that's fee for service, they want higher bed count, they want more admissions, they want all the things that hospital administrators typically got credit for. On the other hand, they're in this payment model, which is well, now we want you to be more efficient and do all these other things. So it's hard for them, and I think to the extent that depending on your local area, the more you can have harmony amongst the providers, the easier it is. And places like Kaiser in California have the advantage that they can sort of build their system internally and harmoniously. So again, my cliche, so the devil is in the details. I'm not sure the picture I would show my kids, but nevertheless, it turns out that too often in healthcare we take a word, managed care, HMO, and we'll say, someone like me will say, this HMO saved money, and then if well then every HMO will save money. That's not true. How you set up the models, the details in my longer talk, the details of the way they set up the ACO regulations in Medicare were A, loopy, and B, problem, it created problems, so the details matter. And the other thing is one size doesn't fit all. So the big problem the federal government has is they are often constrained by having to have a set of rules that work everywhere, and they have to be fundamentally fair, which sounds like a good thing, but it turns out what that means is they have a much harder time going in and preventing aspects of fraud or working with providers that have unique situations. They have problems, so socioeconomic status matters. It's very hard for the federal government to write that stuff in, whereas private sector folks can go in and understand organizations have unique challenges, and they may be a little more flexible for some organizations than others because they can negotiate. And so there's, and I think even if you were to look at the alternative quality contract, and I would defer to the Dana and the rest of the folks here from Blue Cross Blue Shield, is although it is basically the same contract for everybody, it's not exactly the same contract for everybody. There's negotiation things that they can do when they think it's appropriate. And again, in that case, I think it's true that the big issue here is both parties have an incentive to make it successful. So the details matter. Our evaluation of Blue Cross Blue Shield, and you should know we were fortunate enough to publish a year 1, a year 2, and this is a year 4. We had different control groups. One of the things, Dennis said the data doesn't lie, and that's true, but you can't pick different control groups. And so the challenge is sort of methodologically. Now we found with similar control groups, with different control groups, very similar findings. But so just so you understand, groups joined the AQC in different cohorts. So there was a bunch that joined in 2009, 2010, 2011, 2012. We evaluated their savings in year 1. So for example, in 2009, year 1, they saved about 2.3%. That's the first year for the first cohort. Some of that is because some of the groups joining had already had similar type arrangements, so that means the intervention was less for them. By the 4th year for that cohort, they were saving 13%. If you look at the second cohort, so these people were joined in 2010, in their first year they were saving about 3%, then 9%, then 14%. The cohort that joined in 2011 was 7%, and then 10%, 11% almost. In the first year of the 2012 cohort, which is the last one we evaluated, they were saving about 5%. Roughly half of this is in pricing, and there's some big things that happened. And I've talked to Gene Lindsay, who was at Atrius, and Atrius moved their referrals from Brigham and Women's to Beth Israel, both of which are wonderful hospitals. I have colleagues that work at both. I work in an organization affiliated with both, but I'll tell you, one is cheaper than the other. So there were referral and site of care changes. It turned out that physicians, when given the incentive to shop and the data, turn out they shop. In many ways, they might shop better than consumers. And then some of it was in utilization. About half was in utilization. So for example, cardiac spending dropped by about 7%. And there was a big reduction in angioplasty and stents. We think that was in like the number of stents that were being placed. So there's all these little things that you learn about medicine. As an economist, you had no idea, like they're going to start stenting you, but they don't just stent you with one stent. There's some question as to how many stents can go and where, and there's some uncertainty. And there was some belief that there was too much stenting going on, and there was reduction of that. The same was true for imaging, particularly high-tech imaging. We actually saw an increase in standard imaging. So it was a shift from like MRIs to X-rays and a reduction in imaging. We thought there was going to be a change in orthopedic services because there's a notion that there's a lot of too many back surgeries and things like that. We actually didn't see that, and we didn't see it. We didn't look for 4 years. We only looked for. This is actually only 2 years of. We didn't do the service-specific analysis for 4 years. We only did it for 2 years, and after 2 years, we also didn't see an impact on drug spending, which I have to tell you. So there's a lot that one might do to take on the drug industry, and we thought there'd be a lot of places where you might see reductions in drug spending. We didn't see it here. It could be because there was already benefit design programs working on drugs, so the payment didn't matter as much. We did a qualitative analysis as well. It was actually done by Rob Mechanic at Brandeis, and in fact, they agreed with these basic findings. I do think going forward, we just don't have the data. If you look at some of these new drugs, that there could conceivably be an effect on them, although I don't know. But anyway, we could identify specific things. And my general sort of overall view of this is things that people thought were overused were dropping across the system, imaging, for example. They were dropping faster in places where the organizations had an incentive to drop them faster. It just enabled you to do things that you wanted to do more quickly, as opposed to cutting out things that you think are really good, but now we can't afford them. In fact, I don't present here, but the satisfaction was the same, if not better, and all the quality metrics, of which there were many, were the same or not better. So my view of the AQC is it saved 10-ish% after 4 years and gave you better results. So some of the savings of which, of course, get shared, which is another, just as a general rule that people don't ever seem to understand. In a shared savings model, which all of these are, the savings get shared. That's what shared savings mean. It means you share the savings. I'm reporting the savings. Some of them got shared. Anyway, so in the ACOs, there was $20 less spending. In our view of the results, it's about 1.2%. Well, actually, this was the original results that I think L&M presented. In our result, actually, I'm not sure. So some of these, our evaluation of it ended up being 1.2%. And now I'm not sure which ones I put on this slide. Overall, the view of the ACOs were they saved money. I think the number I would keep in mind would be 1.2%. They improved care, particularly for sicker patients. What ended up happening for the ACOs was they all went after the sicker patients because that's where the money was. They did it through various case management type of strategies. It turns out that the patients liked that. So the strategy was not deny care for sick people. The strategy was engage sicker people, and they tend to like it, and you saw higher ratings for care amongst the sickest people. The means in spending, in access to care suggested that they actually were getting more access to care. So the concern when I was at the Mass Medical Society, which is actually in a room somewhere close to here, I was on the Massachusetts Medical Society's task force for health reform. All the physicians that were nervous of this in the 4 or 5 years ago said, well, we're just not going to see people because you're not paying us to see people. It turned out the opposite was true, that in fact more people got seen, because the idea was you want to engage the people where the money is to manage their care, move them to a less expensive setting in a whole variety of ways. So generally people, and again, this isn't a Blue Cross Blue Shield slide. This is a Medicare ACO slide. We're evaluating the pioneers. So the last thing I want to say about payment reform in general is, and this is in part because of the experience I had at Harvard, there's more waste in the healthcare system than people commonly believe. So people that spend a lot of time with the healthcare system understand that there's waste. So this is a slide from Don Berwick and Andy Hackbarth. There's a whole version of this that talks about a whole bunch of different types of waste and the amount of waste. It's basically you're paying too much, you're buying care you shouldn't have, you're getting that care from sites where you shouldn't get the sites from. There's people who aren't being kept healthy enough, and so they're what they call failure of care delivery. You're not keeping them healthy enough. There's a lot of waste. Some people say 30%. There's a big movement to get rid of waste in the healthcare system. If you follow Choosing Wisely, which is an initiative by the American Board of Internal Medicine to identify wasteful services, we've been publishing a lot of work. Internally, we've developed a set of metrics that allow people to quantify that waste. I've been working with Milliman externally, and my colleague Mark Fendrick. Milliman now has a tool, they call it the waste calculator, to measure how much waste is going on. You only get 5%. Most waste is hard to code. But the key point is you want to get rid of waste, and the reason I bring this up now is we have a paper under review, so don't tell anybody because it's not good, that actually shows that systematically in these payment models, there's a greater reduction of wasteful things. So we see an overall 1.2% savings. We see about a 4% reduction in our measures of waste. And in the end, that's sort of what we at Harvard have tried to convince people when we said, look, we want you to use less care. They all got mad. We said, well, we really don't use less wasteful care. Now, there's a question about how to do that. We largely do that through benefit design, which I'm going to talk about in a minute, which has its own challenges. But the key point is, in the end of the day, if you could target and measure well enough, you'd like to get rid of the waste, things like that, and that's
Mike, you talked about providers liking the fact that they're being paid to do the things that they wanted to do all along, so it's going to start to become aligned. Do you think that that's the case on the waste front, or do you think that the data suddenly points?
I think an enormous. This is actually so. I should say, provider organizations want to have harmonious incentives. It's not clear they would rather them be risk-based versus fee. I think my general view is they would rather them be fee-based, but they want the fees to be good. Right. The problem they face now, and why I think this transition will move forward, and it did it in the 90s, is not because I think these things are wonderful. I think they're fine. I think the fees that they're facing, particularly from the federal government, from other places, the fees and the cost, if they don't do something like this, They'll be faced with fees and cost sharing that the patients won't use as much care, which is a problem in a fee-for-service world. They often won't pay. So again, if you go to another setting, the bad debt concerns that certain providers have become enormous if you make people pay. One way or another, healthcare spending will slow. And if you do it through charging patients more, there's all kinds of issues, which we did that, so we can argue. But anyway, so it's not that I think the providers love it. It's just I think they want harmony. When you give them these types of models, the key thing for the providers is how they manage the risk and the money within. So when you're taking money out of imaging, you don't have, the market for radiologists, my department chair, Barbara McNeil, is a radiologist. The market for radiologists is much more challenging in a whole variety of ways than it might have been in the past. The same is true in cardiology. I have a friend whose son plays soccer with mine who's a cardiologist in town. It's been hard on certain professions, so I don't think that people who have been making their money in these areas like as much some of these new incentives as a general rule. The organizations tend to do better. I think, for example, primary care, which has been off beleaguered, I mean, primary care has had real problems, and these don't solve all those problems, but it helps in the grand scheme of things. So, again, and I say this somewhat as an academic economist, evaluating any of these things has to be done compared to something else. It's very easy to complain about all of these things, the details, the philosophy of it, and I actually agree with many of the complaints. The problem is, what's the alternative? One of the alternatives, if you don't think we can make payment reform work, and there's a lot of challenges. It's easier in a place where there's big delivery systems, but just to be clear, it is not, and this is a relatively optimistic talk for payment reform, I do not believe that this is going to be simple, organizations are going to do it, and in 5 years we're not going to be worried about healthcare in the right ways. The actual details of how organizations do this and how insurers do this and how they work together is a very hard thing to happen. It varies based on locality. It is in many ways a heavy lift, and there's a lot of people that are skeptics. I tend to be more optimistic, but there are a lot of skeptics. But the key question is, well, what's the alternative? If you don't do this, what are you going to do? The answer is largely benefit design in a whole variety of ways. And historically, benefit design was very simple. We just charge people more for their premiums, higher co-premiums, or charge people more at the point of service, higher co-insurance, higher co-pays. That's frankly what we at Harvard did for a whole variety of reasons, but basically, and I am embarrassed to say this, it was just the easiest thing to do that got scored the best by our actuaries. And by our actuaries, I mean our consultants. So we have consultants that are employee benefits consultants. It turns out their power is enormous because they're the people that make the slide deck that you look at in the meeting. I have a job that is not involved in doing this, but when we do this, we go into a meeting and someone had to make the slide deck. The slide deck has the numbers, and that's what you have to deal with in the meeting. And it turns out it's just easy to do. We had a, just for those who care, this is a little bit therapy more than speaking, but we had a 95% actuarial value plan. We lowered it to a 91% actuarial value plan. That's still above platinum, and everyone yelled largely at me. So anyhow, but you see this in Medicare supplemental. No one's excited about just raising co-pays or co-insurance. We're not excited about that in general, although we did it. So there's a lot of novel benefit designs that are going on in the country. Reference pricing, tiered networks, and value-based insurance design. And I'll say a little bit about, well, let me say something about them now, and then I'll show a few slides. Reference pricing is you pick a service. Colonoscopy would be the stereotypical one. You look at, there's a huge range in prices. For us, for childbirth, for example, there's a 40% price difference between our most popular place, happens to be a more expensive place, and another really, really good place in town. So the consumers, patients don't really understand the vast differences. Colonoscopy, similar thing. Reference pricing, you pick a service, you pick a reference price, and you charge people the difference if they go to the more expensive one. That requires some level of shopping and some integration with information and a whole series of things. And you can only do it for sort of commoditized things, and that's really what the issue with reference pricing is. Tiered network, which again, if you're in the right market, and again, markets will vary which one you could do. I like tiered network a little bit better in the sense that you can get the entire system engaged. It helps both in steering patients, I'll show you some numbers. It also helps in negotiation. So again, a story I tell, and if I'm going long, just kick me off the stage. But I was once buying a car with my wife, and she said to me, and she didn't realize she was within earshot of the salesman, which is what the problem was. She said, I don't care what you do, just get the car today. And it wasn't great. But it turns out it's hard. I mentioned pricing, which turns out to be important. It's hard to negotiate with providers if they know at the end of the day you need to have them in their network. right? Just independent of whether they should or shouldn't be in your network. It's hard to negotiate with someone if you aren't willing to say, well, kick you out of our network. Tiered networks sort of give that leverage, in addition to moving patients around in a variety of ways. And so I tend to be a fan of these benefit design packages. Value-based insurance design is different. So tiered network and reference pricing, they focus on where the patient's going to go for a given service. Value-based insurance design focuses on the service the person gets. So there's this variation in services. So for example, I mentioned raised copays I was talking earlier. It turns out that one of the downsides of what we did is you now have to pay more to have a baby. And so no one wants to discourage people from having babies, apart from me, even if you don't like kids. I mean, babies are, first of all, the baby's going to come out. So there's not a lot of great incentive effects, and it's not where you would want to put them. Whereas there's other places that are wasteful. I mentioned ideally you would like to target the higher copays to the things that are more wasteful. Value-based insurance design talks about aligning copays. So you have low copays for high value things and high copays for low value things. But there's complicated communication issues in deciding which is which in that. So reference pricing evaluation done by Jamie Robinson in California for CalPERS, but they found huge differences. 21% increase in volume at the low price facilities, 34% decrease in the high price facilities. The price changes that I mentioned, they found decrease in price at the high price facilities. They were now correct, lower price, low price facilities. There was somewhat of a decrease in the low price facilities. There was a huge decrease in price in the high price facilities, and CalPERS had a lot of savings. I don't like the savings number because I don't know what the right denominator is, right? $2.8 million, that would be a lot more for us at Harvard than it is for CalPERS, right? Just percentage-wise. But in any case, they did save a lot of money, and the thing that you should take away from this is that economics works, which is true. Tiered network, again, it's system, it's not service specific, so that's a certain amount of price savings and movement, but on a very small share of the overall business, right? They're just moving the things that they were able to reference price, which is a small share. There was one evaluation of a transparency tool, so I don't have a lot of transparency discussion here, although these transparency tools like Castlight are a big deal. And you may have a transparency tool that the Blues do, I don't know. But in any case, they reported huge savings on lab tests amongst users of the tool. So you have to worry about how the denominators are. Tiered networks tend to be bigger in terms of what they can impact. We found in the evaluation of the Blue Cross Blue Shield tiered network, and what I think, this came out in the Journal of Health Services Research, but I think had a really, really good research design for a bunch of reasons I won't go into, but the top line version is they were full replacement tiered networks, and so you didn't have to worry as much about selection issues. But in any case, we found about 6-7% of patients moved from the non-preferred to the preferred. So you could read that as small. I viewed that as, people tend not to move a lot. So moving 6% of people is, in my view, a win. We're working now to figure out what the overall cost of the program is. But again, this doesn't take into account any beneficial effects on pricing. And it's sort of a one-year version of what goes on. So again, our view is you do good things when you make people face the prices of the variation across the services that they get. And of course, it is more challenging because you have to figure out how to communicate that to them so they know. And a lot of this whole consumer discussion that we're having focuses fundamentally on the notion that you want to get people engaged in their healthcare more. And I'm an economist. I believe that that's a good thing, but there are challenges to doing that. The information's complex. People sometimes resent it. It's hard to figure out how to communicate it. They will make choices that you don't want them to make. So if you just raise copays or coinsurance, for example, they will not use care that actually you think is important, chronic care management services, for example. So that's why value-based insurance design tries to focus on that. But in any case, benefit design is a strategy you can do. My personal sense is most people would rather not have to do it through benefit design because one aspect of insurance is you want to actually insure people and manage the risk. This means that the sicker people are paying more in all of these benefit design things. On the other hand, they tend to be somewhat easier to do than the harder to lift a payment. You can do these without having the same engagement with the delivery system, for example. So anyway, my view of both of them, this is peanut butter and jelly. My colleague, Mark Frederick, uses this all the time, although I guess his version of the slide's not as blurry as mine. Or maybe I'm just old and my eyes are bad. But in any case, they aren't either or. Where I think we're going in the future is how to merge benefit design strategies with payment reform strategies and other strategies to come to a somewhat holistic thing. It turns out that in the world, there tend to be teams of people that do payment reform and other teams of people that do benefit design. But as we move forward, having benefit design a little more synergistically connected to payment reform is probably a good thing, and I think you'll see that in Medicare as they try and, ACOs, for example, have no control over their benefit design. They're responsible for a population. They can't have any tiered network to try and keep them in. They can't change the benefit design to discourage use. If people get more generous Medicare supplemental coverage, that costs the ACO money. The ACO can't really manage that. So I think there's some notion of harmony amongst those products ends up being important, and I think we're sort of at the early stages of that right now. So that's my talk. I'm sorry if I went too long.
No, you didn't.
I'll stay for a minute.
And so, before I open the floor for questions, I guess the big question, looking back into the crystal ball again, Dr. Chernu, is what do you see the future holding for these contracts? Do you see, providers needing to consolidate to, take on this risk? Do you see insurers putting more risk on providers in terms of the percentage of at risk?
I think this, my personal view, recognizing from my earlier slide, I have no idea, but I appreciate being asked. It makes me feel it's important. Is I think there will be a trend towards consolidation of providers, which you're seeing in a whole lot of places for a whole variety of reasons, many of which not necessarily great. That has a plus side is they will be able to take on these risk contracts better. It has a downside related to negotiation. And I think the future will have a lot to do. If healthcare spending, once we get over the hump of the ACA increasing national healthcare spending, and we'll see how the court case is good. So there's a lot of things that are going to happen in the next few weeks with like the court case and stuff. There's Medicaid expansions. If we get over all of that, if 2015, 16, 17 sees continued slower healthcare spending, I think we will largely stay on this type of path as organizations begin to perfect their ability to manage. And across the country, I know a lot of large insurers in general, and I certainly know what's going on at the Blues. I sit on something called NICM, which is a collection of Blue CEOs. Collectively, there's an enormous amount of energy to move in this way, and I think providers are slowly coming on board with that. I think they're trying to figure out basically how their business model can work when their business model changes. It is hard. In many sectors, business models changes and people have to be very nimble. In healthcare, for a variety of reasons, people are not used to the business model changing. The doctors aren't used to the business model changing. There's a bunch of aspects of things that happen when business models do change, disruptions, which we don't want to tolerate in healthcare in quite the same way. We get outraged when there's problems. But I think one thing that is clear is the business model that we had through much of the past 20 or 30 years is not a business model that's broadly sustainable, so the business model will change. And I think increasingly the reason why I tend to be on the more optimistic side of this transformation is because I think providers, not when I necessarily speak here, but when I talk to the AHA or when I was at the American College of Cardiology meeting in San Diego. Cardiologists are very old school in a whole variety of ways. But they, I think, also understand. So just based on the people that are willing to listen to me, I think we're going to see some combination of consolidation and attempts to make this work. And whether it'll be good or not depends on our ability to, frankly, our ability to execute. I think the potential's there, but we have to execute. And remember, like last thing I'll say, no one's trying to lower healthcare spending, which you need to understand. They're just trying to slow the rate of growth. If we could lower it, that would be great. But the win here is largely to lower the rate of growth. Make sure that, so anyway.
Agree.
Are there other questions?
Questions for Dr. Chernu?
Straight out insults are fine.
Well, and this isn't a shy crowd.
Have you looked at the elasticity of the tiered networks and how well they perform depending upon competition in the geographical area?
No, so so that's a terrific question. So I've been doing a lot of work, I've been doing a little work in aspects of network adequacy and tiered networks related to that. And so the subtext of that question is, tiered networks are a great strategy if there's competing facilities in the area that you can tier. If there's only one hospital, it's hard to use a tiered network, or for that matter, a reference pricing strategy. And we have not been able, I have known no one who's been able to see how differentially they work when there's more or less competition. I have given several talks at the FTC, the Federal Trade Commission, And this is a well-known problem. Our regulatory system regarding antitrust is somewhat antiquated in terms of how to deal with these basic issues. And in fact, there is a concern that a move that we just talked about, which is the move that I think is actually probably going to dominate, which is a consolidation of providers, will in fact mean that benefit design strategies like tiered networking are less effective in a bunch of ways, and payment reform could be more effective. But even payment reform has to worry about consolidated entities, because it turns out that the price that you pay matters. And so the Achilles heel of both of these, payment reform or consumer strategy, tends to be pricing and integration. The problem is you could do benefit design without integration, conceptually. Right? It's much harder to do payment reform, or at least the payment reform that I think is impactful without it. In a place like Massachusetts, where you have 5 ACO, pioneer ACOs, big organizations, it sort of makes a lot more sense. It's easier to see how it works out. Other places, if you're in rural Iowa, it's harder to figure out how this is going to go. And I think in the circles that I circulate in, issues about what should happen. So economists tend to not like price regulation. I tend not to like price regulation as a general rule for a bunch of reasons. But I do think there will be an issue related to price regulation in certain places of the country if healthcare spending growth continues and is perceived to be a widespread problem with pricing. Because the solution of the federal government just paying a higher share of low-income people's care is not a solution that I think we're going to be willing to tolerate. And low income, incidentally, is going to be less and less what you would consider low income. Like, the threshold of meeting subsidies will rise. So we'll have to see. But that is a big problem, consolidation, particularly in the provider system. And apart from consolidation, markets that are too small to support multiple competing systems.
I completely agree. I mean, geographic exclusivity is a big issue. There are 50 acute care hospitals across the country without another acute care hospital within 50 miles.
Yeah, no.
Yeah, that becomes a real issue when you think about this.
And so, again, I don't have it here. A lot of the other work that we're doing, and frankly, a whole lot of other researchers across the country, it's become quite vogue in health economics to study pricing issues. So both horizontal integration and vertical integration. And so this is, there's always in any field sort of set of hot topics. And one of the hot topics in health economics now is to study pricing and pricing issues. But because of the laws, it's hard to know exactly what to do once organizations have consolidated. It's much harder to go after the next post. And it's even harder to go after the next post when they can argue, but look, we're more efficient because we're integrated, we can do all these things. And the other thing that's also probably true, maybe not in this group, is going after post-acute. Like in Medicare, post-acute, it's just a huge, huge, huge issue. Anyway.
Other questions? Well, Dr. Turner, thank you so much for your time. Very interesting talk. Now, I know you can't join us for the afternoon, but thanks again for joining. I'd like to introduce our panel now, if I could, to join me on my right, in order if we could, so that we can keep some semblance of order across our panel. So to my right, Dana Safran from Blue Cross Blue Shield of Massachusetts, then Eric Helms, Blue Cross Blue Shield of Rhode Island, Shara McClure from HCSC, again, Illinois, Texas, Oklahoma, New Mexico, and Montana, but we did ask her to speak specifically about Texas and Illinois today. But feel free to ask questions of all of our panelists. And then Troy Page from Blue Cross Blue Shield of North Carolina. In order to just kind of give a baseline of the markets across the country, I thought that we'd give just some time for opening comments among our panelists to talk about their market, specifically just the geographic market, the models that they have, the payment models that they've been able to put in place to date, and also I'll ask them to look in their crystal ball, if they could, as to what they see the next 3 to 5 years holding. After those comments, we have left time for open Q&A. If you have a burning question during the prepared comments, feel free to ask, but we will leave plenty of time for open discussion after these comments. So with that, I'll turn it over to Dana.
Great. Thank you, Dennis. So I'm going to spend a little bit of time talking about the Blue Cross Blue Shield Massachusetts Alternative Quality Contract, or EQC. Luckily for me and my time management, Michael already actually told you quite a bit about results. What I'd like to do is really three things. First, just give you a sense of, why was it in 2007, before all of this, that we began to think very seriously about payment reform, design this model, some basics about the model, what the results have been, and then finally, as Dennis said, not quite the crystal ball, because I have some information. It's not totally looking into a crystal ball about where are we going next, what are some of the remaining challenges, including how we're moving payment reform to PPO. So in terms of context, in 2007, as Massachusetts was in the early months of implementing coverage reform, that was when we turned our attention to payment reform. And we did that because looking back over our medical cost trends, and not just our own, but medical cost trends locally and nationally, it had been double digits year before year, looking back as far as we could see. And we understood that our best lever for addressing that was the way that we pay providers. And, to some of the points that Michael was pointing to, lowering prices had never really worked, because when we lowered prices, we just saw utilization go up, and, you didn't actually get the impact, and not to mention the fact that it didn't do much to improve quality. So we set out for ourselves the twin goals of significantly slowing the rate of growth on medical spending, in particular, cutting it in half from where it was, which was 10 to 12%, and improving quality and health outcomes at the same time. So those were our twin goals as we designed payment reform in 2007. And all of you know, we launched our first global budget quality contracts, AQC models, in 2009. What's different about that model is that a provider who comes into the AQC agrees to be accountable for care across the whole continuum for their patient population. So prenatal care to end-of-life care and everything in between is their responsibility, the cost, the quality, the outcomes of that care. And so just pausing for one moment to realize how different that is from our traditional fee-for-service payment, where the provider is accountable for the patient in front of them for however long that encounter lasts, whether it's a hospital stay or an office visit. As soon as the patient is out the door, their accountability is done. There is no accountability for outcomes in a traditional fee-for-service model. So an ACO model or a global budget model that creates accountability for total medical spending and outcomes actually creates providers transforming care, changing the business model, the way that Michael was talking about it. Changing the business model is not something we can do with benefit design. So I love the peanut butter and jelly. We are working so hard to have benefit designs that complement the power of what we've been able to achieve with payment reform. But we don't kid ourselves to thinking we could ever have achieved the magnitude of quality and outcome improvements or cost trend improvements through benefit design alone that we've been able to achieve by just fundamentally changing the way we pay our providers. So this summarizes the cost results of the AQC in the early 4 years. The top left corner of this graph is really just a different view of the data that Michael already shared with you. These are the results from his team that show, very interestingly, that providers' ability to find savings in the system, first of all, happened from day one. First year they found savings. Well, that was not predictable, right? After, churning away on a model of incentives that are all about doing more, to in their very first year figure out how to do less, how to use facilities that cost less, was not necessarily predictable. And I'll talk in a moment about the role that we played in supporting them, which I think has helped us be successful from day one. But even as interesting as that is, I think more important is that you can see them building momentum over time, every single year, finding additional savings, additional waste that they find in the system and extract from the system. So those savings going from roughly 2% in year one all the way till about 10% off of trend in year two. And that is, he didn't say that much about this, but the control group design that he had is critical, right? Because this means that the 10% is over and above what was happening in the environment, right? Because he already showed you those graphs that said trends were coming down. So is this just the artifact of trends coming down? No, this is over and above what was already happening in the market. The AQC group's achieving an additional 2% in year one, an additional 10% off of trend by year 4. The bottom right side is also a really important view because he joked a little bit about, when there's shared savings, you share the savings. But this idea that, well, trends are going down, but then we, Blue Cross, are paying providers rewards for what they're doing, both on the savings side and on the quality side. So the question gets asked, well, what about the total cost of care, right? After the medical trends go down, but then you add back dollars to reward your providers for the quality improvements, the health outcome improvements, and the savings that they've achieved, what's happening to trend then? And the bottom right slide is showing you that, and it's really impressive in our view, because what happened there is that by year 3, which is the 2011 mark that you see there, we had achieved what was our 5-year goal of cutting trends in half. So trends before the AQC, as I said, were roughly 10 to 12%. By 2011, total cost of care with the incentive dollars included was 5%. By year 4, it was below the state economic growth. It was 1.3%, and then year 5, 2013, it was 1.2%. So beating even what the state set out as an aggressive benchmark of having healthcare grow no faster than the rest of the economy. And remember, before we started this, healthcare was growing at many-fold faster than the economy, right? That was the problem. So a remarkable achievement, but put it together with the fact that this wasn't just taking costs out of the system, this was actually making care better and making our members healthier. And that's what these two pieces of the slide are showing. On the left side, the blue line representing our Blue Cross of Massachusetts quality numbers over time, the red line showing national comparison data. And you can see how much our quality was improving while national quality was really not improving very much at all. But even more dramatically and more importantly, improving health outcomes. And what that slide on the piece on the right is showing is control of chronic disease for patients who have serious chronic illness like diabetes, hypertension, cardiovascular disease. Illnesses where if they are in poor control, bad things happen, right? Blindness, cardiac events, death, stroke. Those are the things that happen when those conditions are in poor control. And what these groups were able to do by changing the business model, right? Not just by using lower cost of care settings and using less care when more care wasn't the appropriate thing to do, but by making care better, by changing their staffing models, by doing some of the kinds of case management that Michael talked about that was happening in Medicare. This was happening in the commercial side because providers, understanding that they had incentives on achieving these outcomes and on managing total cost of care, had to think totally differently about what their job is, right? Suddenly their job is thinking about what happens when that patient is walking out the door. How well are they able to manage their diabetes, their cardiovascular disease? What can I do that helps them manage it better? That's the way they achieved these results, where you can see in that blue line by the 4th year, 74% of patients with serious chronic illness in these populations were under good control. Whereas nationally, the number hadn't budged. Outcomes hadn't improved at all from roughly about 62%. So that is, some of what we're really most proud of in the AQC. Just to quickly say that a big part of this has been what role we as a plan have played in helping providers to succeed. Because putting new incentives in place and just hoping for the best we felt was too risky of a strategy, particularly with respect to managing total cost of care. Providers didn't know the first thing about that, most of them, right? And if they failed, where would we be? Back to negotiating, just rate increases on fee-for-service. So we created this model called AQC support, through which we use these 4 main strategies of sharing data, actually providing on-site consultative support from quality improvement experts and medical directors, best practice sharing forums, and some formal educational curricula that create a four-part robust strategy to help them know how they're doing, to learn from each other, to use data and information to really transform the way that they deliver care. So here's the crystal ball part. We now understand that with all of this success, it is time to move what we've been doing, this payment reform model, to include our PPO members, right? As of today, 93% of providers in our network are contracted this way, almost our entire network. But it's just on the HMO side of our business, which is roughly half of most providers' Blue Cross commercial business, and it is roughly half of our commercial business. They want to provide the same great care to the Blue Cross members who have PPO coverage, and they want the incentives to do that. We want them to have those incentives. We want them to use all this terrific infrastructure and new care models that they've put in place on our whole membership, but we don't want to pay more for it. And so we've designed a model that will, from day one, reduce the total medical trend while improving quality and outcomes, the same way we have been able to achieve in the AQC. And the additional challenge in PPO, though, is our PPO products are national, right? So we have to be able to rely on our Blues brethren and sisters across the country to put in place similar types of models that will return value through their provider networks for your employees and their family members who live out of state, live in other Blues markets. So we've been working with the association and with the other Blues plans to put in place both the programs, but also, very importantly, the data infrastructure that we need to share information back and forth that allows other plans to know what they need to know about the Blue Cross and Maac members that they are hosting, and for us to know about their members that we're hosting. And so this final slide is just an illustration of that, and to tell you that at this point in 2015, nearly the entire country has a Blues plan that has one of these value-based contracts in place with providers in their market. And by 1/1/16, 45 out of the 50 states will have one of these value-based programs with providers in their network, designed to create accountability for total cost of care, quality, and outcomes, so that we can deliver these results in a national, seamless way. And we've accomplished the important methodological and infrastructure changes, like the data exchange I talked about, and like the very important piece of work on attributing members who have a PPO plan to a primary care provider. Because as was talked about earlier, our HMO members tell us who their primary care physician is. Our PPO members have one, but they don't have to tell us that. So we have two choices. We could ask them, or we could use the data that we have to figure it out and then verify it with them. The latter is the path that we've chosen, and we've spent a couple of years actually validating the model that we developed, both sharing it with our providers and with our members. And I'm pleased to tell you that over 95% of the time, both the member and the provider say, "You got it right. That's my doctor," or "That's my patient." And so moving forward, we have a lot of confidence, and very importantly, providers in our market have a lot of confidence that we can do attribution in a way where the data is accurate and where it's not going to, change every year, that these patients who are theirs actually are theirs. So that's what I wanted to share with you as an overview of where we've been and where we're going. And let me pass the torch to Eric to talk about Rhode Island.
Yeah, and I would say despite our geographic proximity, many aspects of the Rhode Island market are very different than the aspects of the Massachusetts market. And I would say that regardless of whether you as plan sponsors have your employees and family members mostly locally, you inevitably have folks living in Rhode Island, just given that geographic proximity. So, Eric, thanks for joining us today.
Absolutely. Thanks, Dennis, and thanks for the invitation today. So I'm relatively new to Blue Cross Blue Shield of Rhode Island, and I came from Michigan, and I thought, well, 1.1 million or so residents, 1,000 primary care physicians, how hard can it be, right? I work for a couple weeks, get this place to, anyway, not so much. Very disaggregated primary care community and health system environment in Rhode Island. It's nearly 100% a PPO market, so some of the challenges that Dana was speaking to, we've been grappling with by design and by necessity. We needed to figure this patient and member attribution stuff out quite some time ago. Again, we have 1,000 primary care physicians. Approximately 2 years ago, none of them were organized into a system of care or in an integrated delivery system. 80% of Blue Cross Blue Shield of Rhode Island's payments, facility payments, go to two health systems. One hospital delivers over 80% of the babies in the state. So when Michael spoke of rural Iowa, I thought he was going to say Rhode Island. It's got similar challenges. So some of those market techniques that he was speaking of are challenges that we face as well. And we are working on developing out tiered networks and working on some pricing strategies, but I wanted to just lay out sort of 4 pillars of work and activity that Rhode Island is working on together with the primary care community, largely based in deep-seated relationships, long-standing relationships with the physician community and the provider community, but it is very much a market that's in flux, and we're working really hard to mitigate some of the same challenges that, again, Dana was referencing. We were seeing year over year, in particular in the commercial large group market, about 7 to 8% year over year trend. We don't see that. We do have a large book of Medicare business, and that's been a key area of focus, and we did expand Medicaid in Rhode Island 2 years ago. We also have seen the exchange take hold in Rhode Island, about 50,000 lives or so, give or take, and so all of those dynamics are influencing the work that we're doing. But first I'm going to just talk about some policy influence that we've been working on with the state in terms of thinking about how to affect and work more closely with the provider community. It's really in 3 key areas. Roughly around 2009, 2010, we had what's called a primary care spend mandate. So incrementally, year over year, insurers were asked to increase the amount of spend on primary care by 1% off a base incrementally each year. So we're shunting more and more of our payment into the primary community. Rightfully so, our primary care physicians were getting maybe about 102 to 103% of Medicare payments at that time. And so we've been leading the charge in that space, and I'll talk a little bit about our work in the patient-centered medical home, because that's been the foundation of that. And again, that started in about 2009. Secondly, we have mandates now, price controls in the commercially fully insured market, where we are not able to exceed a price increase of more than 2% annually year over year for fee-for-service to the facilities. And that includes a component part of that required to be tied to quality payments for facilities. So we take that very seriously. Part of the challenge we have is that they don't, the Health Insurance Commissioner does not have purview over the Medicare line of business that's governed by the Department of Health in Rhode Island, nor does that necessarily influence how and what we can do in the self-funded space. But we do apply those price controls to our entire commercial book of business. So that's had the net effect of blunting commercial price trends over the last 7 years, where now our commercial price trends are at or below inflation. We still have other challenges on the utilization side, and we were coming off of a base that was exceedingly high. And then thirdly, right now we're working with the state in terms of a transition to broader payment strategies to fee for value. So a proportion of our total payments will be shifting from fee for service to fee for value, likely still sitting on top of the fee for service chassis that Dr. Chernow was speaking of, but they are actually talking about establishing thresholds for a portion of payment being fee for value. Now we recognize there's potential for some unintended consequences here, so we're working very closely with the state, the other payers, and the providers, frankly, to make sure that we're not driving misaligned incentives we want the contracts and the relationships to be the right ones for the providers. We also don't want them taking risk or any other downside incentives that they can't currently manage. The second area of activity has been organizational redesign. So we've been paying for the development and advancement of the patient-centered medical home infrastructure now, again, since 2009. Blue Cross Blue Shield of Rhode Island led the charge. About 50% of our primary care network now sits natively within a patient-centered medical home. We know that that's not the complete and desired end state. Our goal, frankly, is this broader integration into systems of care. We don't actually see integration as creating market leverage as much as it really does get rid of that waste, and we see a lot of waste right now in the disintegration. A lot of providers trying to compete on the wrong things, and not do it as effectively or as efficiently. Plus, the other part of it is we see a lot of care leaving Rhode Island, some of it appropriately, some of it not. So there's a value proposition there for the providers as well, for them to become clearer about what they're able to deliver in terms of the health care for Rhode Islanders, keeping it local, and when it needs to come to Massachusetts or go elsewhere, then that's fine. But that's an opportunity we see as a win-win for our providers. We are standing up several specialist collaboratives as well. But one of the key differentiators with Blue Cross Blue Shield of Rhode Island is our ability to take and work very closely, and again, those deep-seated relationships, sitting at the table and designing programs that you won't see anywhere else in the country. We spent 14 months developing a maternity bundle where for uncomplicated vaginal deliveries, the woman having a baby at Women and Infants Hospital, Care New England, is going to get the lowest price possible in the market. And again, remember, that's where 70 to 80% of all births are in Rhode Island. So we've developed a maternity bundle collaboratively, co-designed it, that's launched and it's live, and attached to that is a quality promise. So there's a whole quality component of this that's wrapped around that we're delivering to the market and really trying to differentiate the moms and the babies and the family's experience. The other opportunity that we developed out recently is some work with a local behavioral health provider called the Providence Center in Care New England as well, in helping support the behavioral health care continuum. We're actually basing that work off of some work that they had done in the Medicaid space, where they'd seen 15% reductions in behavioral health over the course of 2 years, again on a Medicaid population. Behavioral health is one of the leading drivers of trend in Rhode Island. We've got to get our arms around that, and so we're acutely focused on the behavioral health spend again, and that's in the commercial setting as well as the Medicare setting. And then lastly, network design. So we are working to develop out tiered networks. The issue is when you have 80% of the births at one hospital and you have almost all of the acute care at the other large health system, that really starts creating some disconnects in the market. So we've got to think through that, be smart about how we do that, and maintain the access that our members and your employees require. And I'll just speak to the third, some payment reform. So again, I mentioned bundles. We've transitioned 50% of the market in under 2 years to shared savings. There was no shared savings, no risk contracts in 2013. Now, fully 50% of the providers are in a shared savings contract, and 25% of them are in shared savings contracts with some downside risk wrapped around total cost of care. This has been a major transformation, and a lot of the challenges that Michael and Dana spoke of exist for us. Better information is critical. We're developing out a statewide disease registry, an all-payer disease registry, where alerts for patients that are in an inpatient setting that are coming through the ER, et cetera, are available at a physician's desktop, real time, closing gaps in care. Our market, we didn't have to compete on quality for the longest time. NCQA was not really a relevant differentiator in the Rhode Island space. It's a requirement now that you're NCQA accredited to be on the exchange in Rhode Island, but we saw massive opportunities there. So as we work to support the triple aim, this is a cost, quality, and member experience strategy in terms of moving the physicians to this integration strategy. But the last piece that I'll say is, as we think about this integration, we are creating disincentives in the market right now as we speak for independent physicians to stay independent. And what I mean by independent isn't that they have authority and autonomy to make the decisions around their business decisions in the community, but practices of 1 or 2 or 3 primary care physicians are not going to succeed in this market. And so we are actually moving our fee schedules, our product strategies, where we're investing in, for instance, nurse care managers, embedded pharmacists, et cetera. That's all going to be moved towards integrated systems of care. And we actually are starting to see the impact of some of the patients at a medical home and the system of care integration. We've started to see about 2% reduction year over year in terms of total cost of care, and we've seen our quality and our member experience skyrocket. Our quality scores have gone up 7% just in 2 years, and our member experience, we're actually, frankly, focusing on doing a better job of measuring that. And we have one of the leading MSSP providers in the country in Coastal Medical who knocked it out of the park, both in terms of the financial but also the member experience component of the shared savings initiative they were in. So a lot of work, but we, for a small market, we're trying to come at it from a lot of different angles, but really leveraging the relationships and our localness to get that work done. And crystal ball, it really is for us about this integration, working collaboratively with the providers and making sure that our actual stated target in our 5-year strategy is to have 85% of our primary care base natively sitting within a system of care that's more fully integrated.
Very helpful. Shara, I think very interestingly, all of our panelists represent different geographies and very unique features of the different geographies, but I would say that your sorry, I moved it forward for you.
You did it, sorry.
Yeah. I would say that you represent 5 very different states that have a lot of variation even within those geographies. And then your native state, Texas, has a whole lot of variation even within that state itself. So very interesting, and thank you for being here.
Thank you. I'm really happy to be here. I traveled from Dallas yesterday, and so this has been a nice trip. And as Dennis mentioned, and all the other panelists have mentioned, every market is so different in healthcare. And as HCSC covers those 5 states, each state has a different legislative environment, each state has a different competitive environment, and our provider markets are different as well. And when you think throughout the country, who's delivering care? You have a few national organizations. You have HCA. They have a lot of for-profit hospitals throughout the country. You've got Tenet. You've got DaVita. There are a few buzzwords, a few names that are kind of consistent throughout the country. But most all care is delivered by those local physicians, local not-for-profit hospitals and systems. And so it makes it important to maintain those local relationships and understand that provider community. Even within Texas, as Dennis mentioned, we cover 254 counties, 4 major markets. There are a dozen markets within Texas that have 200,000 or more residents. So all of them are just extremely different. And so that's why within HCSC, we don't have just one model or one solution for value-based care. We have several different solutions. And the point is, we want to try to meet that provider where they are, based on their capabilities, based on their size, and based on their appetite for risk. So I'm going to cover 3 examples of these different models, and we're going to kind of take the Goldilocks approach. We're going to start with a model that appeals to small physician groups, and then we're going to move to a very large ACO model that we have in Illinois that's working for us. And then we're going to kind of hit the middle, and we're going to talk about this joint venture that we've just entered into in Texas with the Texas Medical Association that's going to allow, as Eric mentioned, really enable the independent physicians to remain independent, because that's where we see the future. That's where we see where providers can compete in population health, and compete not only with each other, but compete with those large systems that seem to be consolidating. So kind of stepping into this program, first of all, this small program that I mentioned, the program that independent physicians and large groups alike can participate in. And this is Bridges to Excellence. Bridges to Excellence is a third-party quality measurement organization that recognizes excellence in certain specialty areas. We have formal programs in Texas for diabetes care, cardiac care, and asthma. And these independent physicians who earn their Bridges to Excellence designation, they get special treatment in our provider finder. We can have employers tier their benefits to these Bridges to Excellence physicians, and through our care management programs, we often refer patients to these Bridges to Excellence physicians. And so I'm just going to, very quickly, what kind of return on investment have we seen? We've done studies with our diabetic population, and we have had these programs in place in diabetes for several years. And so what we've done is we've taken the total cost of care with our diabetic population that are seeing Bridges to Excellence physicians, compared that with total cost of care for the diabetic population that's not seeing Bridges to Excellence physicians. And every year we measure it, we see a huge difference in that per member per year cost. The last time we measured, that difference was about $550, but we've seen the results as high as $1,200 per member per year. Cost saving advantage by seeing these Bridges to Excellence physicians. So they're not only cost savings advantages, these are the physicians who are managing the hemoglobin A1C rates, who are getting the preventive care. So anyway, this is a huge program for us. It is endorsed, it's been endorsed by the Texas Medical Association in Texas and the Harris County Medical Society. We try to work with our local physician organizations. The Harris County Medical Society actually got a grant to get local master's students to go out to physicians' offices and help physicians get these designations. So it's been a widely adopted program that's delivering quality and cost advantages for our membership. So let's go on to these ACO programs. When you think about ACO programs, or at least when I think about ACO programs, I think about population health managed by large integrated delivery systems. In Illinois, they have several large integrated delivery systems who have entered into these agreements. The Advocate Health System, which is the largest ACO in the country with Blue Cross Blue Shield of Illinois, they were started back in 2011, I believe, and they are delivering really nice results as well. Lower emergency room rate, they're beating trend by 3%. And Illinois, they have about 450,000 members in these ACO programs, and and 700,000 members in an HMO program. So they have over 1 million members in these value-based care programs. Again, these are programs that help manage populations. They include a shared savings component, a care coordination component, and data sharing, much like several other programs. So now let's move on to this independent physicians, how independent physicians are at a crossroads. In many of our states, including Texas, we're seeing several of these independent physicians trade their independence for employment. I don't know if you saw the Journal of American Medical Association study that came out recently, but it compared total cost of care delivered by independent physicians, physicians who are in groups, and then physicians who are employed by hospitals. That difference, when you compare independent physicians to those in groups, that's a 10% total cost of care difference. When you compare independent physicians to those physicians who are employed by hospitals, it's almost 20%. And I'm sure you can imagine why. The unit costs at hospitals are higher than at freestanding radiology centers, freestanding imaging centers, and those employed physicians are expected to deliver a return to those hospitals. So we've recognized in Texas, just as many of our other states have, that keeping those independent physicians independent, it should lower the rate of consolidation where, we don't want to end up with just monopolies in our markets in Texas that drive those prices. We want to have competition, and we want to keep those independent physicians independent. So we have entered into a joint venture with the Texas Medical Association. I don't know if you are familiar with the Texas Medical Association, but they are one of the most powerful medical associations in the country. They have 48,000 physicians that they represent in Texas. They drive legislation every year in Texas, and they are strong advocates for their constituents in Texas. We joined this partnership with the TMA. We are minority owners. TMA is majority owners. We have joint governance. But what this brings to Blue Cross Blue Shield of Texas, it gives us a way, again, to keep these independent physicians independent. We think it's going to allow for a better way of managing populations in Texas, creating competition. And to the TMA, this helps them keep those independent physicians independent as well. It helps them serve their constituency. And another thing it brings to us with our providers, TMA brings a level of trust. We like to brag at Blue Cross Blue Shield of Texas. We were started in 1929. We've been around for more than 80 years. TMA's been around for more than 150 years. So together, we bring a powerful message to those independent physicians. We will start up our first group 1/1/2016. And this is a huge investment for HCSC, and we'd like to think that this will translate into not only a better way to manage care, but more products and services for our employer groups. So I just wanted to touch on, again, 3 different areas where we are transforming healthcare delivery from fee-for-service to fee-for-value. Again, meeting those providers where they are, but encouraging them to move along that continuum.
Thanks, Sharon. So on to North Carolina. I know that a lot of folks in the room have populations in North Carolina. I think once you start getting outside of the Triangle, Charlotte, Asheville, you start to get rural really fast, and it is a very unique market. I think not by choice. We've seen a lot of our population in Massachusetts move down to North Carolina. And I think that it really is a unique market, and appreciate you being here to join us, Troy. Thank you.
Thank you. I can't remember, do you happen to know, are we number 2, number 3 in terms of host Blue
I think
Cross?
it's number 3 for us, yeah.
So yeah, we're way
Very
up there.
closely aligned.
Yeah, a lot of businesses have employees in North Carolina. So a lot of folks up here have mentioned provider consolidation. That is I'll talk a little bit about the environment in North Carolina. That is a big issue across the country. It's definitely a big issue in North Carolina. We've got, by my latest count, about 4 different health systems that are kind of the major players in this area and are kind of buying up and snapping up other providers as they can. Carolina's healthcare system, they're out towards in the Charlotte area. Duke and UNC, of course, in the Triangle area, and Vidant healthcare system, which is in the eastern part of the state. And so, just talking about provider consolidation for a moment, it's not just your standard purchases, that you would normally think of in terms of consolidation. It's also management agreements. So I'm not going to buy you, but I'm going to manage certain portions of your business, and I'm also going to contract on your behalf. Which is really the worst of both worlds for the payer, because you get the consolidation without the integration, and so they get the leverage from coming to the table with more providers under their belt, but you're not getting any economies of scale. They're not combining systems as much. It's really just a leverage play. And of course, that's squeezing independent providers. It raises prices, and they have. If a provider has control of a given market, I think we just mentioned before that I think you said 50 acute care hospitals across the country don't have another within 50 miles. I don't know how many of those are in North Carolina, but it feels like we've got definitely got our lion's share of that. And so the question is, well, how do you respond to a market like that? And what we're really doing is a three-pronged approach, and I'll go through each of these. So a lot of these providers are not ready for ACOs or risk sharing. They're either not ready, or they're not sophisticated enough, or they just don't want to. And so we do have quite a bit of fee-for-service contracting, and of course we've talked previously, that creates sometimes incentives that are not great. If you're getting paid per unit, guess what? You're you're going to try and move more units. And so the challenge there really for us is how do we get the value analysis into how much we're willing to pay for fee-for-service. So I'm going to talk about value-based fee-for-service contracting. Then we have some providers that are more sophisticated, and they're saying, yes, I would like to take on risk. I do want to be responsible for the population health. I'm prepared to do that, and I'm capable of doing that. That's our alternative payment arrangements. And then lastly, I'm going to talk about fostering competition, which is easier said than done in a market where provider consolidation and a lot of rural area come into play. So just to jump in to one provider type, just to keep it simple, in North Carolina facilities. So for value-based fee-for-service contracting, you'll see from this little graph, it's for the mathematically challenged. I really could have done one column here instead of having just two sides of 100% there. But in 2009, we had 11.3% of our facility, by allowed amount of our facility contracts were through a contract that took quality into account in terms of how much we would reimburse. And now in 2015, we're up to 80%. In the next 2 years, we want it to be 90%, and I'm sure shortly thereafter, we're going to go for 100%. The idea there is we need to pay for value. Everyone, you've heard the term value. It's cost and quality together. Gone are the days, or should be gone, are the days where a facility or health system can just approach you and say, this is how much I need from you in revenue, and I need a cost of living increase, and I'm just demanding this amount of money. The value they bring to the table needs to be a part of that discussion so their incentives are aligned appropriately. They need to earn their increases. On the professional side, it's for health systems and facilities, it's a little more simple because you can be a little more uniform in terms of how you set up these programs. On the professional side, it's a little more complicated because you've got so many different kinds of specialties and so many different kinds of measures. I think we're more like 30-40% currently on allowed spend on just professional contracts, but we're working on growing that number as well. This is our quality scorecard, and I won't go through it in too much detail, or actually any detail. But when we contract with a health system today, as part of to get that number up to 90%, we get our clinical folks together with their clinical folks. And we work out what the quality measure should be, where they are baseline today, what they're trying to go for, how we're going to tie reimbursement to their achievement of those goals. There are 4 main goals, and you can see the percentages. I think they're just illustrative beside there. But leadership commitment to quality is going to comprise 10% of the whatever amount of money we're tying to quality, and so that's essentially being a PCMH, joining these sort of formalized programs that are geared towards improving quality. We've got improving health outcomes, sort of those standard measures like HEDIS measures and things like that. And we've got lowering costs, and so sort of taking into account how efficient the cost part of the value proposition, how efficient the facility is, and then improving the patient experience, which is always important. So the idea is we don't want to incent less care, we want to incent the right care. We want the patient experience to be still good, we want the quality to be good, but we want to get some waste out of the system. So actually, I'm talking about, at this point, value-based fee-for-service, so it's all prospective. So none of this is sort of writing the check at the end of the measurement period. It's all, okay, what are you going to get paid this year? As an example, we're going to measure how you did last year, and your payment for this year is going to be based on that, and then the same thing's going to happen the following year. So it's a little more real time. So we also have alternative payment arrangement. Sure, I got the right. Am I even on the right? Yes. Right slide. Programs. Others have talked about their ACO work. We are in that space as well. But again, not everyone's ready, especially in North Carolina, ready and able to effectively have an ACO program. But we've picked out the ones that are. So Wilmington Health, Cornerstone, Wake Med, and the Alliance, which is New Hanover Medical Center and Wilmington Health together, and they're actually natural competitors, so it was kind of a coup for us to get them to be in an ACO together. And we've also got bundled payment arrangements that we've been applying, and with a great deal of success. The numbers we've actually been able to come up with are 10 to 30% savings, depending on which provider we're talking about for knees and hips. We're looking at developing and enhancing the bundled payment arrangement. We're investing in a company, or not investing, we're buying a tool from a company called Aver Informatics, which is a bundled reporting tool, which is going to help us to kind of routinize the administration of bundled payment arrangements better and be more efficient at it so that we can expand more. But even for bundled payments, which are a lot simpler, believe me, than ACO arrangements, not everyone's ready for that. And so we're not going to be going out and negotiating dozens or hundreds of bundled payment arrangements. We're going to expand appropriately. Probably going to expand the kinds of services that are under bundled arrangements. So we'll add shoulders, spine, maybe bariatric, but we're going to sort of be very careful and contemplative about which providers we do these kinds of arrangements with. We are looking at additional kinds of risk contracting, and really, from my perspective, it's important, especially in our market, to break down that distinction between just straight up fee-for-service contracting, where the incentives are aligned inappropriately in terms of cost, versus sort of alternative payment arrangements where the incentives are aligned towards being efficient. We're trying to figure out good ways to have those kinds of appropriate incentives even in the fee-for-service world, and I'll talk about that a little bit. The last prong is fostering competition in an environment where sometimes there isn't so much competition, head-to-head at least. So some things we're doing there are we have a tiered network product called Blue Select. I don't have the numbers handy, but it's a PPO product with a tiered benefit depending on whether you're tier 1 or tier 2, and that's a cost and quality determination. And it's a relatively small portion of our business. We don't sell, that's not our biggest seller, Blue Select, but we are finding that it has a disproportionate importance to the provider. They want to be tier 1. It's important to them to be tier 1. They especially don't want to not be tier 1 because they failed for quality. But even if they meet it for quality, they want that designation is important from just a pride and politics and reputation perspective. So we're finding that that's having a benefit on hospital in terms of health system behavior, even outside of the relatively small membership on those products. It's interesting. We have hospital and professional negotiations where we're negotiating our entire PPO network. Blue Select, again, is just a small part of that, but we spend a really outsized amount of time talking about their tiered designation. Another product we have, Blue Value, which is a limited network product, is interesting as well, especially in light of this next product, Blue Local. So the reason I'm kind of talking about those two things together, in our markets where there is health system competition, the question is, all right, how do we actually get them to compete on value? Historically, my experience has been it's sort of the reverse of what you would expect in terms of competition. If Hospital A finds out that Hospital B is getting paid more than Hospital A on something, they're not they're not saying, great, I'm winning this competition, I'm the cheaper of the two options. They want to get paid that higher amount. It's kind of competition working in the opposite direction than you would normally think of, and that has to do with transparency and whether people shop for healthcare and that sort of thing. So what we've done in the Charlotte area, and we're looking to expand that where it's appropriate to do that in North Carolina, where there is competition, is actually create a situation where these hospital systems can compete and will compete on price. So our Blue Value product, which again is limited network, we have made Novant, which is a big health system in the Charlotte area, exclusive for Blue Value. And then Carolina's healthcare system says, hey, what are you doing? That's my biggest competitor and I'm not in this product. Well, we created a product called Blue Local for Carolina's healthcare system where they're exclusive. So it's sold in the same market, head-to-head competition. And the message to both of and we've been very transparent about how we price the product and how healthcare costs flow down actuarially into that price. And so these two health systems understand the healthcare purchaser is making a choice between the two systems at the point where they're buying the healthcare product itself, not when they need the care. And by the way, of course it's important for you to have a good reputation in terms of quality, but price matters now because we saw the slide from Dr. Chernow before about healthcare costs as compared to income. Price is one of the, if not the top factors in terms of choosing a healthcare product. And so the response to these two providers is, you want to capture more of the market, you want to beat out your competition, you need to lower your not only your price, but have appropriate utilization so that we can price this product lower so that you can win the market. And again, we're looking to expand that same model to other more urban areas in North Carolina. Another thing we've done, I will go out on a limb and say they're bold moves in terms of transparency. So you'll see the timeline here. We've had sort of the standard, if you're a Blue Cross Blue Shield North Carolina member, you can, if the service is shoppable, kind of see what the relative costs are and quality and so forth for different providers. We took it a step further and actually opened up our transparency tool to the general public. And so 80%, and this was 1/1/2015, so currently on letstalkcost.com, anybody can go out and see the total cost of care for 80% of our elective non-emergency procedures and compare providers. And I came out of our legal department, by the way. I was an attorney for Blue Cross for 20 years, and I'm relatively new to this role. My first thought was, oh my gosh, someone's going to sue us. That's the reaction, is we're going to get challenged. Can you even do this? Isn't this proprietary? Can you even put this information out there? Well, politically, it's kind of difficult for a provider to take the position that transparency's bad. And I don't want that out there. Well, the question is, what do you have to hide? And so we've had interesting response. It's still too soon to tell exactly what the impact of this transparency move is going to be. But I can tell you the kind of conversations we're having with providers. It's not, can you do this? The first reaction we get is a bunch of providers saying, yeah, these numbers can't be right. It's showing me as, I'll use knee surgery as an example. It shows my total cost for a knee surgery, I'll make the number up, is $20,000. But my buddy who works in my same practice and is under my same contract, it's showing $17,000. So why is it different? It can't possibly be different. And our answer is, it's total cost of care. And if we dig down into it, your friend is doing the surgery at an ambulatory surgery center, you're doing it in the hospital. It's more expensive when you go to the hospital. That accounts for it. And so we're getting a lot of aha moments with providers where they see changing some of their behaviors can actually impact the cost for the member. Another response we're getting, which I think is interesting, is hospitals coming to us, especially those that are essentially monopolies, and trying to rebalance their pricing, which we are resisting, by the way. And so they say, they don't say it this way, I'll just say it with my editorial slant. They'll say, for the shoppable services that you have on your web, where people can see how much this costs, I'd like to keep those static. I'd like to we can even cut those. I want to be more competitive. But by the way, I don't think we've got the non-shoppable stuff. I don't think we've got that priced quite right. And if you do the math, they're essentially just squeezing the balloon. They want to, for the shoppable stuff, they want to look, the outpatient stuff, they want to look competitive, but they still want to keep their revenue intact. And I think that's sort of an old school, old guard response to this changing world, and hopefully we're gonna be able to break through that. So I'll close it out by saying, what do I see for the future for Blue Cross Blue Shield of North Carolina? I don't see ACOs and bundled payment arrangements across the state with every provider. It's still going to be the sort of relatively few that are able to administer and understand and work under an arrangement like that. But I do see more transparency, more real-time reporting to providers, even if they're under a fee-for-service arrangement, about how they're doing in terms of quality relative to their peers, cost relative to their peers, and giving them foreshadowing, or maybe that's too nuanced a word, specifically telling them this is what you're headed for at our next renegotiation. You're too expensive, your quality's not good, you're not probably going to get any kind of an increase. We're probably going to be talking decrease, and if you want to have an impact on that and have a different discussion with us when your contract comes up for renewal in 2 years or 1 year or whatever it is, these are the things you need to focus on, so that when we have those renegotiations, even under a fee-for-service world, we are, in a way that the provider can understand, relating our negotiation position to their value. I think that's it.
Yeah. Troy, thank you. Just thank you quickly to our panelists. So I definitely want to open the floor for questions, but the first thing that jumps into my head when I'm thinking about payment reform contracts and what I've heard from Dr. Chernew and our panelists is kind of a mix, and I've heard the same question asked in the market too. So I'll throw it out there first, and I'm imagining many of you are thinking the same thing, is what's the drafting effect of these contracts versus what is or halo effect? I've heard it termed a bunch of different ways. And what is actual brass tacks differentiation between a contract like this and maybe other products in the market or competitors? Because when I think about it, there's inherent benefit of the data exchange that goes to providers. And that data exchange, when a provider is willing to take that risk, allows them to act on something that they wouldn't have received before. And so that's clearly a differentiation point. When you look at the way some of the providers are changing behavior in terms of the way that they're staffing, we've seen in Massachusetts at least, and I know, I've heard these stories across the country too, when they're hiring case managers to manage populations that they're at risk on, they're hiring those folks specifically for those patients. So they are truly actually treating patients differently, which was interesting too that we saw. And then you hear stories like in Illinois, the advocate system that has someone literally triaging folks coming through the door to identify whether they're in a risk contract or not, and if they are in a risk contract, identifying if that's the most appropriate site of care for them. And so you've got someone that works for the facility, consciously making decisions whether that facility is the right place for that person to be. But the gateway to that discussion is, are you in one of these contracts or not? And so I think I've heard plenty of information that points to that there are many items that are not kind of draftable. But when you start looking at the data, what do you see in the market? And Dana, I know we've had some conversations about this too, and there's actually been some studies, published about it as well. Do you want to start?
Yeah, sure, I'd be glad to. So, this question about halo effects or spillover effects has been a really important one because we've been so far out ahead of our local competitors. And so we have two formal ways of having looked at this in the data. One is a study that Michael Chernew and his team actually published in Journal of American Medical Association a couple of years ago, where they looked to see before Medicare implemented its ACO program, did Massachusetts providers who were in the AQC appear to be providing, I'll call it AQC-like care to their Medicare beneficiaries. And therefore, the question being, was Medicare saving money because of the AQC compared to the non-AQC providers and how they were caring for their Medicare beneficiaries? And what they found was that there were some things that were spilling over, and there were many things that were not spilling over. And it's very much along the lines, Dennis, of what you outlined. So the kinds of things that spill over are the kinds of things, I like to describe them as the things where through the work of payment reform, you have changed how a physician thinks about what the right thing to do is. And now they just do that for all their patients. So if you have shown them data about generic prescribing, for example, and they now see that they have been an outlier in prescribing brand medicines and that all their peers, including right down the hall from them, are using generics much more than they do, and they start to change to using more generics, they're not going to do that just for their Blue Cross of Massachusetts HMO members on whom they have a risk contract. They're just going to do that. But it turns out there's not that many things in healthcare that are that way. In fact, a lot of what these organizations are changing in order to succeed in the risk contracts require much more kind of proactive, thoughtful dedication of resources. You use the example, Dennis, of the case manager, and our provider organizations are very candid about that, right? All the new staffing models that they've created, they're not spending a minute of that person, that valuable resource's time, working on patients for whom they don't have an opportunity for shared savings or earning potential on quality. Those resources are going to help prevent readmissions and improve outcomes for their patients on whom they have risk. And similarly, on the quality measures, what the Chernew study found and what we see in our own data is a lack of spilling over to quality improvements. And I think that has to do with the data sharing, right? Because we're giving them this actionable information at the patient level about how they're doing on quality measures, and they have a financial reason to want to do well. So they're using the heck out of it. We've started to give them the same information for our PPO members in advance of the PPO incentives because we saw in our own data that they were improving better on the quality measures for our own HMO members than they were for our PPO members because not everything spills over, right? You get what you pay for most of what's going on. So that's what we know about spillover effects, and the bottom line is some things spill over, but many important things don't. You have to actually incentivize them in order to make them happen.
Sure. Cher, I saw you nodding as Dana was talking and asking the question. Do you agree?
Well, I agree there's both.
Yeah.
So one example, I'll just kind of elaborate on the advocate example. One thing that I understand as part of this advocate example, it changed the conversation. It started changing the conversation between how much are you going to pay me on a fee-for-service basis to how much are you going to pay me to manage this population. And so there have been unit cost benefits, whereas advocate historically kind of received above market increases because now they have a shared savings component. Now the unit cost increases are below market. Because advocate wants to succeed in those shared savings programs. So on one hand, yes, they are triaging the patients, and those who are attributed and in the model get that maximum benefit. But of all the patients advocate sees with Blue Cross Blue Shield of Illinois, fewer than half are actually attributed. So the whole one spillover example is that all those members get the unit cost advantage. So again, a little bit of both.
Sure.
I think we've seen the same thing where both are in play in our market as well. So to the extent that we see the spillover effect, actually, as we led the market with some of our patient-centered medical home strategies, we actually now are participants in a broader all-payer patient-centered medical home strategy where we've driven more consistency in the market in the last several years across the payers. So it's not the Blue Cross model and the United model, et cetera, Tufts model. And so by being first in the market, leading the way, others are drafting on behind, and we've actually created a different conversation in the market about expectations around the primary care space. And again, to Dana's point about where maybe it's not drafting as much and the spillover isn't there, I think what we're starting to see is organizations are mobilizing and catalyzing resources differently, regardless of whatever kind of resource it is. It's really about how they're bringing to bear their resources in a completely different way. An example of what we've done in the last 12 months is embedding pharmacists into the practices to support medication therapy management. We've seen very early but very positive results with about a 3-to-1 ROI on that investment. We have practices coming to us now asking for that additional support because they see the value within the other practices. And so that's actually one area where we're still differentiating ourselves in the market, but we're trying to get closer and more collaborative with the provider. And again, this was just about thinking differently about a resource. These people were sitting in our walls or were out in the market, but it's just how we've deployed them and how we actually get them to execute differently. And I think there's some benefit there of thinking about how we've been using these resources. And so that's, again, where I see some drafting, even though the spillover isn't quite happening yet.
Other questions? I should have had name tags up here, but if you're directing your question, you've got Dana, Eric, Shara, and Troy. Unique concerns about your geographies?
I guess I'm very interested in hearing more about how you're taking the ACQ model that you've been able to successfully utilize with your HMO product and expand that on a national PPO. Boston Scientific has employees across the country, huge base of them in Minnesota, California, Massachusetts.
So I'll take first shot around kind of the national front, but also, Dana, you can chime. Yeah, sure. Repeat the question, sure. So the question was, how are we taking what we did for AQC in Massachusetts on the HMO, making it available on PPO, but also making it available nationally and taking advantage of the national programs that you've heard, across the table today. So I'll start with the latter part first. On the national front, you heard from a few folks talk about how important reporting, analytics, and support is for providers in order to make this change. And I think it's no more evident in terms of the difference across the markets than when you heard Dana and Troy talk about their markets. And in Massachusetts, you had providers welcoming and asking for heavier weighting on outcomes measures. And in North Carolina, you have providers saying there's no way I can possibly be responsible for what my patients do after they leave my office. And so you've got very, very different opinions. And how do you take the different models that you have to put in these markets and make them successful in a single national view? And the start of that is sharing data differently among plans. So the data that's needed to act on all of these contracts will start transmitting, and actually it's all through testing, and so it is in large part being transmitted already between Blue plans today to allow the local providers to see data on your employees and their family members that reside in non-Massachusetts markets. So we will share that data back with that plan so that the providers see a full view, not just their members, not just their patients that are members of Blue Cross Blue Shield in North Carolina, but all of their patients that are in these contracts. And so home and host, as we call them within the Blue system, membership will have full data transfer. So that's the big lift for the system, is to allow that data transfer to happen. The second piece is to have a threshold that all of these programs have to meet in order to be credentialed as what we're calling a Blue Distinction Total Care Provider. And so every model across the country that you hear about don't necessarily meet the criteria to be a Blue Distinction Total Care Provider. And so that bar is going to be continuously raised, but you heard a lot about upside and downside risk provisions. You heard a lot about what the providers are going to be responsible for managing. There are minimum thresholds for all of those contracts to actually be considered Blue Distinction Total Care contracts, because at the end of the day, this is not a marketing effort. These contracts have to show value in order to be considered Blue Distinction Total Care contracts. The contracts are largely already in place too, and I think the benefit across the system, to Dana's point, is we're not going to pay for the innovation that they've already taken on. And so you're taking advantage of innovations that have already been achieved and are being achieved across the country, and so you're going to see immediate value from these contracts. So nationally, in terms of data exchange, in terms of identification of these providers will also be identified on the provider finder so that folks will identify Blue Distinction Total Care providers. And then I'm foreshadowing a bit because we will talk about this, but then the ability with critical mass starting in 17 to be able to limit or tier the network, showing favor to these particular providers as well. Dana, do you want to talk a little bit more about the branching into PPO in Massachusetts?
Well, I think Dennis covered it pretty well. It probably mostly answers your question. The little bit I would add, just two things. One is, so every single Blue plan for PPO has to have a fundamental attribution approach, right? All of this relies on figuring out who a patient relies on for primary care and creating accountability for that individual. And none of these programs do it at the individual doctor level. It all has to do with critical mass of an individual in the organization that they're part of, even if it's a virtual organization, like some of my peers have talked about. So attribution and accountability that the provider has agreed to take for total cost of care for that population and for quality for that population. All the programs have that. But then the other thing that I would emphasize that I think you heard this morning is, part of the value of the Blues network is that all of us are embedded so deeply with the providers in our relationship. We are a huge part of their market share, in some markets more than others, but always a predominant payer. And so we have their attention and we know them. We have real on-the-ground relationships. And so working with them, I think it was Shara who used the sort of expression of starting them where they are. I think in most parts of the country, the AQC or global budget model is seen as the destination model, but it's not necessarily where everyone can start. And so what the Blue Distinction Total Care Program and the benefit of the relationships that all these plans have with their local provider organizations allows us to do, create that accountability for the population, but know how to work with them for real on the ground, because we're not, a remote payer with some, not real relationship, to share data to help them move along to where they can accept a global budget type of contract and to where that's in place. So that just maybe adds
so
a
two
little
other
bit.
obligations that I'd say are incumbent upon a carrier in this world. And the first one is to be able to share back with you, our customers, what value you're getting from these contracts. So from your employees and their family members that utilize these providers, identify what value you're seeing and receiving from this. Two, to help you identify what the incentive threshold or dollar threshold or payment to these providers are so that you can get that full value calculation. It's also critically important. The other piece, and Dr. Chernu talked about it a little bit, is volume becomes very important here. Because for a provider to agree to take on this level of risk, or a provider system or facility group or whoever's looking to get into one of these contracting models, you need volume. And outside of the federal government, in most markets, there's then Blue. And so he talked about 15,000. I think our actuaries would say you need at least 10,000 patient lives. Milliman says you need 25,000 patient lives. Either way, that's a lot. It's a lot of patient lives that you need in order to have a credible data set for a provider to be willing to take risk without huge margins of swing that can happen on either side, that happen when your numbers get too small. And so that's really incumbent upon carriers as well. In order for this to be successful, you need numbers. You need members in order to make this work. Joanne, I saw you nodding too as you heard the question. Did that answer your piece of the question, or did you have an offshoot question?
I think so. I was just trying to figure out, as you know, we have a national PPO.
Sure.
When are we going to be able to endure some of the savings that we hear about?
Yep. So I would say that twofold. One, you heard that there's some spillover effect. I would say that you're receiving the spillover effect now, but the real meat of it will happen when the data exchange starts and your members, your employees and their family members start getting attributed, and the data starts flowing to these providers to start enacting change. That happens 1/1/16.
And then, of course, is security, we're going to talk about that too.
Yes, because more data exchanging hands means greater risk for sure, and so we will talk about data security later today as well.
And Dennis, would you just highlight a bit of the distinction between BDC and BDTC, please?
Sure. So again, foreshadowing a little bit, because we'll talk about Blue Distinction Centers for Specialty Care and Blue Distinction Total Care. Specialty care are the 6 categories that you'll really test my memory if I have to rail them off, but they are complex cancers, knee, hip, and spine. They're bariatric surgery. So those are the categories where specialty care. It's about 30% of an average account's inpatient spend are spent in those categories of specialty care. So they are service-specific, generally planned services, mostly surgical services that are being performed. Those are both cost and quality based, but they look at individual facilities and surgeons within those particular specialty services. Blue Distinction Total Care is wrapping these overarching contracts where providers are responsible for overall risk. So it captures a lot more care and the whole continuity of care, but is not looking at individual specialty services. So Blue Distinction centers for specialty care are, again, service specific, whereas Total Care is wrapping these payment contracts that cover the whole continuity and continuum of care separately. Does that, Eileen, answer your question? Other questions?
With the various value-based payment reform models, are you seeing a shift in responsibility in your health management area? I think in Massachusetts we've seen practitioner hiring of our case managers as the AQC has taken hold in 90+% of our population. I'm just wondering in other markets as you're partnering with these local providers, are you seeing that there's a shifting in the typical responsibilities that you manage as a plan that are now responsibilities of providers, and you're taking on different accountabilities?
Yeah, so this is the delegation question, Mike, and I'm really interested to hear our panelists' thoughts on delegation and the willingness of providers to take this on, but also the ability for providers to take on this responsibility and take it on for different degrees. So some may be looking to do it on the surface for just kind of some chronic care. Other ones may be doing full-on case management. I think we'd all universally agree that we don't want them doing utilization management. But I think shy of that, there's different levels that providers can take on there.
I can start by saying that we actually have been about 80-20, where our care management's actually been embedded in the primary care and medical community directly. Again, more proximate to the care being delivered, organized in a way where they're part of the care delivery team. We do have some care management capabilities that we've retained within our organization, but that's a relatively long-standing model that we've had in place. Actually, we're working now to mobilize resources to actually be in the patient homes. And so we're working with several organizations to advance our in-home care strategy and bring to bear greater physician, social worker, pharmacist type resources, as well as nurse care managers in the home setting. We are actually working with one system right now to delegate services more broadly and include utilization management services. And that's with a new entrant in the market. It's a national provider who's done broad-based delegated activity and work in the California market for over 25 years. And as they've come into Rhode Island, we're using that as a pilot to see if we can gain some efficiencies there. And again, they've been willing to take on a greater risk total cost of care contract in exchange for that. And so that's being done on a limited basis. That's set to go live 1/1/16. That would be our first foray into that space. But we actually see the care management community and provider space being more effective and efficient when we're working to make sure that they're as integrated virtually or live in the care setting directly.
Sherry, your thoughts on delegation?
So far, I mean, with our ACOs and patient-centered medical homes, we have not delegated utilization management per se. I think that's going to probably come more hand in hand with global financial risk.
Mm-hmm.
Our ACOs, whether they be integrated system ACOs or what we call kind of our virtual ACOs through this Texas Medical Association joint venture, we're paying a care coordination fee to really help those organizations hire their own staff to really just do more what we call care coordination, not the authorizations, not the inpatient day management, but identifying. We're helping those care coordinators identifying their high risk patients, their chronic patients, so we give them a bigger picture than just the primary care physician might get. We're helping them identify the frequent emergency room visitors, those who are not compliant with their medications, those who may be seeing a specialist that the PCP may or may not have referred. So they're really trying to close the gaps in care. They're doing a little more just care management, case management, but not really the utilization management. As the models evolve, I could see us moving down that continuum. But even just a care coordinator, I mean, we recognize the benefit of a patient being called in the caller ID saying, Dr. Crow, as opposed to this is Blue Cross Blue Shield calling. So we think even though there might be a little bit of overlap that we're trying to manage, we still think there are overall benefits.
We're pretty much in the same boat in North Carolina. We haven't delegated care management. We view it as sort of supplemental activities, and we try and align and make sure we're working not at cross purposes, but pulling in the same direction, but we haven't fully delegated.
Yeah. Well, I mean, I think you've heard very different views from different markets, and I think it really highlights how different our country is, how different your locations are across the country, and the care delivery system that they access. I know that there are flights that our panelists need to catch, so I do want to thank everyone for your time, but this has been wonderful. Thank you very much. I'm going to talk a little bit about the jelly. And the jelly is how we take our products that we offer to your employees and their family members and really incent the right behavior so that everyone is aligned in order to make the right decisions. Starting with Blue Distinction Total Care. So you heard about some contract discussions from North Carolina, from Illinois, from Texas, from Rhode Island, and from Massachusetts. But it's really about putting these networks together, really putting these programs together. Paying providers differently, but also sharing data across the Blue system differently. But you got to have critical mass to do it. You don't just need the membership with providers in order to get them to agree to these contracts, but you also need to have enough of these programs and enough geographic reach across the country for you to start wrapping products around these types of contracts. So as of the end of last year, we had $71 billion in claim flow through these types of contracts across the country. 25 million members are currently seeing providers that are in one of these contracting models. 230,000 providers and 570 programs. Interestingly, and I chuckled when Dr. Chernu talked about the counts of programs, because I've heard thousands and I've heard 20. In terms of carriers use counts here, because there are so many different definitions of these types of programs. But to give you an idea, AQC, one program. That's counted as one of these 570. When you heard Shara talk about Texas, Texas has different programs based on where different providers are in the continuum of decision making and ability to take on risks. So you see far more programs in a market like Texas than you do in Massachusetts. For 1117, though, our plan is, as we launch the data exchange and value back to providers for 1116 in these contracts. For 1117, what we want to be able to do is to actually limit or tier the network for use of these providers. I will tell you that while limiting sounds very nice, I think, and history has told us that tiering will be more widely successful in doing this. The other reason why I think tiering is going to be successful is if you think about Massachusetts, you see a huge mental block when you tell someone that they're going to have to tell their employees they can no longer deliver at the Brigham. That's a lead balloon for you to share with your employees. But if you were to tell them they're going to have to pay more to deliver at the Brigham than they would at a community-based hospital, that's a different story. And I think folks more widely understand when you start talking about tiering versus limiting a network. The other thing to think about is if you have a very unique type of cancer, there's really very few facilities across the country where you're going to get treatment for that particular type of cancer. And if you're limiting the network, you're suddenly needing to decide as an employer whether you're going to make exceptions for someone to go to that super specialty, cancer center because it's not typically in your network. And for those instances, it is important to use those facilities. So limiting a network doesn't always work. It's very difficult when you start thinking about limiting a network versus tiering a network. And all reasons why I think tiering is going to be more widely successful when you start looking at these types of contracts. Next thing I'll talk about is telemedicine. We've had a few discussions about this. The one thing that I will say is we have made a decision. We have picked a preferred telemedicine vendor. We are in active contract negotiations with them. I can tell you that it's someone up on this slide, but I can't tell you who it is yet. It might, as we talked about things that can hurt your negotiation position, if I tell you we're going to use them, it kind of hurts our negotiation position at the contracting table. Contracting discussions are going very well with this particular vendor, and we are excited about what they bring to the table. So we will announce in July who that vendor is. It will be offered both insured and self-funded. Self-funded customers that don't want to offer this service will have the ability to opt out if they want for this, and it will be available as of 1/1/16. In terms of costs, in terms of per visit and a PS or per employee per month cost, that'll be determined shortly as the contract discussions are still going on. But we will be ready for a 1/1/16 go live. The other thing that I will mention, two things that I will mention is one, last week, not sure if folks saw this, but there was a pretty significant lawsuit filed around intellectual capital from one of these vendors against another one of these vendors for use of intellectual property patents around the video transmission of these services and some other IP infringement suits that are going on. I don't think this is the last. It's the first, but I don't think this will be the last of the lawsuits that are going on. I also think that you are going to see consolidation in the field of these particular vendors too, because in addition to these four, there are probably at least a dozen more that I know of that have kind of gotten into this space as well. That also it does not include the providers that are also building the capability or have the capability to perform this on potentially their own platform as well. The next stage of this process is actually to look out at the active provider community to see who has this capability and see who's willing to offer it in a similar price point as where these vendors offer. Because what we don't want to do is provide access or increased utilization or demand in a place that's not as price competitive as this avenue for delivery. So we are very excited about that piece. The other thing that I will mention is anyone in the room that may have a relationship already with one of the vendors on this screen here, this is not, this does not mean that you have to turn it off as of 1/1/16 or break contracts or do things like that. There will be a period where you can continue the relationship the way it's going. At some point, though, we will either look for you to transition to this relationship or potentially alter the relationship that you have with the incumbent carrier because the way the incumbent vendor, because the way it works right now is not great. It's heavily manual. It allows, it results in providers sometimes getting payment and subscribers sometimes getting payment. It sometimes bumps up against overarching contracts that the Blue plan may have with that particular provider that are different than that provider moonlighting as a Teladoc or an MD Live or an American Well provider. So because of those reasons, those bumps, we're looking to streamline into a more efficient way for those relationships to continue should you choose to do so. But the integrated solution that we plan to offer will be a far more dynamic and user-friendly experience. Questions on telemedicine? Because I'm going rapid fire here to try and get us back on schedule. Reference-based benefits, you heard Dr. Chernu talk about it. This is a bit of an eye chart, but I do it only to tell you that what we are calling smart choice cost sharing. Did everyone see that? We didn't call it blue something or other. Smart choice cost sharing, which doesn't exactly roll off the tongue either, is our reference-based benefit solution. The reason why we didn't call it reference-based benefits is twofold. It seems to have a little bit of a negative connotation in the market. You know, folks think that there's going to be these massive out-of-pocket expenses, you know, passed on to members. The other reason I think it has a little bit of a negative connotation is, as excited as I hear consultants talk about this, and as excited as I hear carriers talk about it, I don't feel the same excitement from employers when we talk about reference-based benefits. And so we took kind of a two-pronged approach here and started with MRI and CT because it's the most obvious place to start, viewed as largely shoppable, with the exception of ER and pediatric, which are excluded from this type of benefit offering. The first one, which is the simplified RBB approach, would be to create a benefit differential. So rather than setting a reference point on an MRI, say at $750, and anything below that reference point, full benefits would still apply, so your coinsurance deductible or copays, however you pay for high-tech radiology today in your benefit plan, and anything above that point, they'd be fully responsible for the cost above that point. That would be what we would term kind of classic reference-based benefits. In the simplified version, you just create tiered cost share. So you may have preferred coinsurance. You may have a lower copay for something below that reference point set at that 70th percentile. Anything above that reference point would have the higher cost share. Both of these models, both classic RBB and simplified RBB, have potential for significant savings. If you think about it this way, in your high-tech radiology spend, again, in the MRI CT category, you will see generally about 20% savings within that category for going either with simplified or classic RBB. That's in year one. Now the studies show, if you look at CalPERS, if you look at Safeway, if you look at Kroger, they saw pretty meaningful savings even in year two on top of year one savings. What they saw was people aren't just buying down to the reference point. They're buying down typically to well below that reference point. And so the savings residually keep happening. What they're also seeing and what they're having difficulty capturing is folks are actually really engaged in this benefit offering, and they're actually using the information to start shopping for other services as well. So we have this capability for 1/1/16. I would say that to get you live and running, we would need at least 120 days notice to get this set up for you in the way that you're looking to have it set up. The thing that I would really stress in terms of importance of RBB is data that goes into the tools that help people understand where the cost of services, where to receive services at or below the reference point. Data density is critically important. And if you start thinking about where there's critical mass of data across the country for transparency and for cost data to be shared with members around RBB, volume becomes a very, very critical advantage for us as a system. The other thing that I would say is you've got to put the right tools in the hands of members. And so we've developed a tool to sit that looks very similar to the member ID card application that we've talked about in past Maac meetings. That plays off of that application that would allow someone to search based on their home zip code for a reference base, or for a service that meets or stays below the reference-based benefit threshold, so that members will know and have access to information that tells them where they can receive care. But an important note on this, everything hinges off of the subscriber, so your employee's zip code. So if the member resides someplace else, if they're traveling someplace else, everything, the reference point hinges off of the subscriber zip code. It does that because there are very important access elements to RBB. And so if someone is not deemed to have reasonable access to a provider that falls at or below the reference point, then the system will automatically trigger the best level of benefit to the member regardless of where they go. What this does for you is really important. It allows you to keep anything that goes beyond the reference point that would essentially be the responsibility of the member, keep that out of your out-of-pocket maximum. So anything above the reference point would not have to count towards your out-of-pocket maximum as long as you have this access provision in place. So as long as someone has reasonable access to a provider at or below the reference point, then there is not the need to have anything that carries above the reference point carried to your out-of-pocket maximum, which allows you to really maximize savings driven off of this program. So thinking about future expansion, I would say you think about the 50th, 60th, 70th percentile for classic RBB. I think where I get really excited is if you can start to tie incentives to stuff below that point. So to come up with data points at the 20th, 30th percentile, and maybe have employees be able to share in the savings for use of the most cost-efficient providers for these services, you can really, really expand upon and multiply upon your savings generated from these programs if you start to have a dual approach, where you're responsible for anything above the reference point, but you share in the savings of anything that's lower. Again, I look at this and say this is going to be a very tough communication road to your employees. But I would also say that once they understand this and live this, they will be far more engaged consumers on something that you would all generally agree is a highly shoppable service. This is also a bit of a pathway to more engagement products down the road, things like tiered networks. If you want to expand your percentage of folks that are in high deductible health plans with either HSAs or HRAs, this is a way to really start to bring kind of consumerism to the forefront. The other thing that I will say is there was a question about the difference between Blue Distinction Centers for Specialty Care versus Blue Distinction Total Care. So these are the 6 categories for Blue Distinction Specialty Care. We are very happy to announce that in 2016, we'll be launching Blue Distinction Specialty Centers for Maternity with very special focus both on the cost and quality side, but starting with PC01, which is early elective deliveries, and then quickly, after we get the full credentialed, going after PC02, which is C-section for low-risk first-time deliveries, which really kind of gets at the perceived elective C-section, which tends to be more common in states like Connecticut and New York, but really getting at birthing centers or hospitals specializing in deliveries that allow these elective C-sections that are far more costly. I think Dr. Cherny was talking about 40+% variation in cost for delivery. So really looking at both cost and quality measures around maternity, but excited to launch from that standpoint. So I really breezed through the product update. Again, intentionally, I'm trying to get us back on schedule, but any questions specific to how we're aligning product offerings with the types of incentives that we're offering to providers? Okay. I'll take that as either the break food really put someone in a coma here, or we covered every possible question that you could be asking. I'm going to go with the latter. But I will also say that with this innovation and with this technology comes risk as well. And so exchanging data with providers, exchanging data back to members, data moving hands has inherent risk associated with it. I think the other thing to keep in mind is when you look at us as a system, we're the biggest player in nearly every market across the country. And so we become the biggest target when it comes to things like data security and data breaches. So it's actually my distinct pleasure to, one, not have to cover this topic. I'm just kidding. But to also introduce Ditzes Voldens, who is our Privacy and Security Officer, and also Bill Cushing, who is our Chief Auditor, to really talk about how we're looking to use data security as a strategic asset, as a competitive differentiator for us in the Blue system, but also to really give you a snapshot of what happened this year, as you've had repeated communication around breaches from both Premera and Anthem, and what we've done to respond to those, but really taking a special lens to what we're doing in the future to differentiate us in the marketplace. So, Ditzes, Bill, welcome. Thank you.
Sit or stand.
Hi, everyone. I'm Ditzes Voldens. Dennis misspoke a little when he introduced me. I'm the the compliance and privacy officer. Bill is the security officer as well as the chief audit executive for the company. So we're here to talk about the Anthem and Premera, the Blues breaches, what happened. So I'll give you a little background into that. Also talk about what we're doing here at Blue Cross and also across the system in reaction to that. So just a little background about the scope of the breaches. So as you know, Anthem announced their data breach back in February. It's February 4th. And Anthem's a large plan. They cover 14 Blue Cross and Blue Shield service areas. And so their data breach had an impact, obviously, not only on Anthem, but on other Blues plans because of the interdependency among the plans in the Blues system. The characteristics of the threat, they called it an advanced persistent threat, and what that really means is it was ongoing for a period of time. It was persistent in that the actors were not going to stop until they accomplished their mission. And it's designed to be active over a period of time without being detected, and which makes it very problematic. So what they're after, these cyber attackers, are not so much to shut down the system or execute a denial of service attack, but they're after the information. So they want to get in, be active as long as they can before they're detected, and then get back out with that information. So at the end of the day, Anthem had determined through its investigation that 80 million people across the country had been affected. So if you think about what that number means, that's 1 in 4 individuals in the country. Kind of a startling figure. And the source of their penetration was one individual. So they were able to gain access through a database administrator's credentials, probably through some sort of spear phishing or email attack, but really sort of playing on the vulnerabilities of a person as a human being and not so much the vulnerabilities of the system. I can't imagine what that sort of the weight of that feels like if you know you're responsible for the breach of 1 in 4 individuals in the country. Shortly after that, Premera was breached, and Premera is active as a Blue plan in Washington State, and Alaska. And the Primera breach was a little different in that the perpetrators deployed malware throughout the system, but similarly it remained undetected for a large period of time, and so it sort of traveled, I think of the analogy of a house. So in Anthem, they were fortunately able, despite the large figure of members affected, they were able to sort of contain the breach to a particular database. In Primera, that malware was active throughout the environment. So at the end of the day, Primera had to consider its entire environment compromised. And so they had 11 million current and former members compromised. So what that translated to for Blue Cross and Blue Shield of Massachusetts was that in the Anthem breach, about 375,000 of our members were affected by Anthem, and in the Primera breach, 51,000 members. So in reaction to those events, there are legal obligations that you need to execute on. First and foremost, the notification requirements to members, our customers, which are our accounts, to regulators, to the media. And so we began immediately the process of planning for those communications. There was a lot of investigation still to be done when word first came out of the breaches. We needed to sort that data, sift through it, be able to divide it among each of our customers, be able to enhance it to understand the latest demographic and contact information for each member. So that was a considerable amount of work, and as you know, we were communicating throughout that process with all of you. So the notice effort was a joint effort between the breached plan, either Anthem or Primera, and us. And so at the end of the day, members received letters from both us and Anthem, or us and Primera, as the case might be. They were offered 2 years of credit monitoring, which was sort of an unprecedented move at the time. What had become sort of industry norm was to offer 1 year of credit monitoring. I think the circumstances of the Anthem breach required something a little more robust, a little more that would add a little value back to the member, and so they decided to offer 2 years of credit monitoring and also offer that without verification, meaning that any member that was concerned about this issue could call and sign up. So I thought that was a very good thing to do, and is probably becoming the market now for future events that are similar. Here at Blue Cross and Blue Shield of Massachusetts, we executed on our incident notification plan. We have a formal plan in place that started with executive. Oh, I'm sorry, we've stayed on that first slide. We're actually on number 2. It starts with executive oversight so that everyone remains informed, beginning actually with the board through our CEO down to our executive leadership team. But then there's a number of operational teams that need to execute the letters, be able to mobilize the member services area for the reaction that we'll inevitably get for an announcement like that. And so those notices have gone out for both breaches, and now we're sort of in the reaction phase part 2, which is, how are we reacting in terms of improving our own safeguards here, our own processes for potentially having to deal with a similar situation again. We've engaged an our internal consulting group to look at our how we reacted to Anthem and Primera, and hopefully improve upon those protocols. Our board is particularly concerned that they're doing the right thing, so they've engaged outside counsel through our general counsel to look at cybersecurity governance, the information that they're getting on a regular basis and have gotten, and see if there's anything that needs to be improved there. They're also reviewing our breach response plan. And then Bill's going to talk about, there's a lot of other third-party work that has been ongoing, but new third-party work that sort of grew out of the breaches themselves.
Okay, that's just.
Do you mind if I sit?
Yeah.
Okay.
Thank you. Good morning. Again, I'm Bill Cushing. I'm the Chief Audit Executive and Chief Risk Officer at Blue Cross. I've been at the company a long time. I've been in this role for the past 21 years. And at the heart of everything I do is risk, the what could go wrong. Many times it's a torturous question, and probably no more so than now with security. And unlike risks that I've dealt with through the years, that you always found a point of containment because things were more static. In the security space, it's one of these challenge areas that the technology keeps evolving. All these mobile devices and the things you can do with it continue to evolve. And, along with the beauty comes the beast. And, so you're dealing with the threat side of things. And as Ditz has pointed out, that this is certainly a challenge for everyone. From our board on down, the scrutiny is very intense. We want to make sure that we show to our customers that we're doing everything in a responsible way as it relates to security. And the board has taken a very hard look at even how they approach their oversight of security. And that's become a big deal. One of the outgrowths of the Anthem and Primera breaches was that the CEOs across the Blues system came together and agreed on a number of actions related to security. And among them was to commission a third party, Mandiant, which is a forensic security company that specializes in identifying threats within environments, to go across the entire system. So within each Blues plan, to actually take a look for some of the footprints that were present in both Anthem and Primera. And I don't know, you may have seen last week that the Office of Personnel Management of the federal government was breached. And interestingly enough, that the information that law enforcement authorities have identified the unit responsible for that particular breach is the same unit that was involved in both Anthem and Primera. I also had an opportunity a few weeks ago to sit in with law enforcement authorities, and they debriefed us in terms of what they're seeing, some of which they can't put out in the public to create a real frenzy. But there were common threads that they said are ever present. And then it's how advanced these threats themselves are. The individuals doing it, the cyber threat actors, they're very well organized, highly skilled, they're well funded. They showed us organizational structures of some of the groups that are doing it, and it looked like a company organizational structure. They showed a marketplace that you would have thought was Amazon, where they had a shopping basket, and there were certain things that you could buy in the darknet, an actual site where you can purchase social security number, date of birth, place of birth, a lot of the sensitive information. They also told us that there are a number of purposes that the threat actors were chasing this information. Some of it is intellectual property. Some of it is really a harvesting of information, and they haven't quite figured out what they're going to do with the data, but having that data allows them to know an awful lot of intimate details about us. So the Mandiant forensic assessment is ongoing across the Blues system. It's also going on within our plan right now. Some of the other activities that the CEOs from the Blues system agreed to is one of the challenge spots in security is it's not a uniform approach to security. There are different frameworks out there that are used by companies. You hear ISO, you'll hear NIST, you'll hear COBIT, COSO, High Trust. It just goes on and on. So everybody seems to do it a little bit differently. And then also third-party assurance. How do you provide confidence to customers, to the executive management of organizations? There's not a uniform approach there either. You'll see that there's a cyber trust certification, there's an ISO certification, net diligence, SOC 1, SOC 2, and I'll work to that in a second. But what the Blues have agreed to do is to come up with a uniform set of standards that all 37 plans will adhere to, along with a uniform approach to third-party assurance. And it's moving toward what they call a SOC 2 now, which is an express focus on security and controls. Some of the activities at our own plan, historically we've always looked at security. It's always been part of our internal audit test work, as well as that which is done by our independent audit firm. The focus has been, the financial statement audit was one place. It will look at security around the areas that affected financial controls. And then what used to be the old SAS 70, then it became the SSA 16, and now it goes by the SOC 1 traveling term, focuses on operational and financial controls at a very detailed level. We've always tested security as it tied into those operational and financial controls. We've been doing that for probably 15 years, so it's not something new that we've done. So this presentation, just as an aside too, we did with our board a month ago to give them a feel for what we're doing in our space from an assurance standpoint. Some of the things we've added this year, we've gone through a tremendous amount of technology modernization over the past 3 years. And that also included moving toward a single claims platform, what you may have heard is the NASCO claim platform. And within those investments in technology, we spent a lot of money on the security side of things to really beefing up the infrastructure. A lot of the tools for monitoring, detecting, and reporting in and around security were a big part of what we've done there. This particular assessment we have up here is referred to as a HIPAA risk assessment. It's more compliance-oriented, but there are certain artifacts that are coming out of it. This is going on right now. This is really to ensure that we're complying with HIPAA, high-tech, and the omnibus rule. But it also gives us some other value that we're going to use as we work toward a SOC 2. Now, SOC 2 is, the SOC itself is it's an acronym for Statement on Controls. It falls under the American Institute of CPA standards. It's quickly becoming the good housekeeping seal among major companies within the United States. And finally, I think we're going more from a directional standpoint to something that most companies can agree on, and that's a big deal. What makes this different than maybe cyber trust certification or high trust certification, those are more point in time, so you don't get a feel for how things are going over a period of time. The advantage of the SOC 2 is specifically focused on security, and the testing that goes on around this takes place over a year time. And so what we're doing this year, we had this on our audit plan back in November before the breaches even emerged, because now we had a stable environment in our own house after all the technology changes that we could do something like this. And we're in the pre-assessment phase right now, and the purpose of the pre-assessment is identify any gaps before we go through the formal SOC 2 assessment, which right now will be the last 2 quarters of 2015. And again, the intent out of these assessments is to provide the highest level of third-party assurance that we can for our customers, that we've taken appropriate action at identifying where the data is and there are effective controls around that data. These, they're busy slides, but they're intended just to show you the timeline. All this stuff is going on concurrently, and when we get toward the end of the year, we should have something for you that you can hold in your hands that's an opinion from a third party that says that we've got the appropriate controls in place in our environment. We are happy to answer any questions. I'm sure there's not much interest in security.
Bill, so with the, I think it was classified as a breach last week or within the last 2 weeks at the Office of Personnel Management, the New York Times published an article that suggested that breach, as well as the other federal government breach, the Radar and Anthem and Care First breaches may all be tied into
Yes.
larger activity in China.
Yes, that's part of the briefing that I sat in on, that the government feels that they go public with these things, it becomes very political. And the interesting part to these breaches themselves is they leave forensic footprints. It's like watching CSI. And they've been able to actually, there are certain characteristics within each of these breaches that tie them to specific units within China. Then it becomes, is it state-sponsored, or is it this unit that's detached from the government, but operates certainly with, at a minimum, tacit approval of what they're doing. And they were very clear with us. They said that, companies should prepare for breaches because there's an infinite number of ways for companies to be affected, and that these threat actors are very patient, and they have the resources, the skills. One of the things, just to add to what Ditz has shared on Anthem, is that you have the main company, Anthem, and they've been acquiring subsidiaries over time. This breach came in through a subsidiary, a newly acquired subsidiary. And although the path for coming in was through a database administrator, the actual attempt to penetrate the Anthem environment went on for over 200 days, and they couldn't get into the main company. So part of the diagnostic, when Mandiant went into Anthem, when they looked at it, they were able to identify that not only did this crowd try to get in for 7 months, that when they eventually got in through the subsidiary that became integrated with the main company, that they sat dormant for somewhere in the neighborhood of 100 days. That a lot of these breaches, it's not like just something comes in and they break through the door and you know they're there. They come in very quietly. They crawl, they lay dormant. They want to see if your security detection in place has spotted them. And they'll lay dormant for days, weeks, months, and then they'll grab something. And again, in a very methodical, calculated way, try to see if they're being identified. And then they'll send the information out of the environment, again, looking to see if they're detected. If it goes undetected, then they come back in and they go for more. So there's a progression to it, and that's the whole thing about, the advanced, it's the sophisticated, the persistence. They can, wait a very long period of time. They're invested in this. And the threats themselves, sometimes it's not the crashing through the door. In fact, most often it's not. You don't know they're there. So it's certainly raised everyone's awareness. I can tell you that it's certainly at the forefront of my screen. As Ditz has mentioned, the security officer in our company reports under me. I have a direct reporting relationship to the board, and the idea is to preserve the independence of my role and the security officer's role. It does get a lot of attention at the board level, and I've been in the space a long time. So I'm really comfortable dealing with the what could go wrong and where was I and all that. Security is I don't have anything in my work life that I can compare it to. It's very, very different. And it's something, I guess the addictive side of it is it's an incredible challenge. But I also find it very humbling.
Bill, I think you talked a little bit about some of the protocols that we've taken on since the breaches, and really started doing even before the breaches. I think it's important to note that because of the source of a lot of these breaches, because of the chance of either direct government funding or passive government funding from some foreign countries here. We do have very aggressive geo-blocking programs in terms of websites and access, so source of sites are blocked in terms of access. I really liked your comment about the Beauty and the Beast comment, because the technology that comes from this is wonderful, but there's inherent risks, and data's moving in more places than it was ever moving before. And so I think our dependency on mobile devices is a great example of that. But mobile devices access a data point to show the information that you're looking for. When that access happens, you've got data moving. And so I think it's really important to note that we're very aware of those things and tracking those things, but also putting in policies as an employer and as a vendor of yours to prevent, to the extent possible, these things from happening. So we can no longer use thumb drives to share data within the organization. We can't access personal email. We can't use file sharing sites like Dropbox. And these are all generally sources for this malware to start attaching back into the system and lay dormant, and then strike its attack where the time sees right. We also monitor a lot of the data and access and chatter within the system, within the IT world. And that's been a source of us to identify potential breaches from our customers, because as they port into our system for secure file transfers and eligibility transfers, that's a port into the system for data to come and go as well. And so we've helped some clients understand that they may have been impacted, not because of us at all, but because of information that we've seen about their susceptibility to something. So we've really, I think, taken this very well-rounded approach.
Yeah, you're right, Dennis. And end user behavior becomes such a critical part in this, because we've invested heavily in that perimeter defense, and then within our system those technical controls, but we have tightened the geo-blocking. One of my jobs is to train and educate our workforce, and so we have an aggressive privacy and security training program, but you can really never do enough. As you can imagine, we're a big company, there's turnover. It's not a one-shot deal and you're done, or that you can do it every 2 years. It's constant, so we make use of every channel of communication we have to our associate workforce, those folks that are entrusted with handling data. We have user controls, and we have policies, and it's a constant effort to train and educate our associates on those.
Yeah. And
this has been very helpful. Will you have more sort of ongoing communications about these plans that we can bring back to our organization?
Absolutely. That in the process, one of the things I neglected to mention is I sit on this cybersecurity committee at the Blues that's finalizing the standards in the third-party assurance right now, and some other pieces around credit monitoring and fraud detection activities as part of the commitment of the Blues system. They truly want to make this a differentiator. They've taken a very hard line across all the plans. They've made the security standards and assurance and some of the other activities a new license requirement. And this license requirement, is the card-carrying privilege of using the trademark and trade name. And the CEOs have to attest they are conforming to these new standards. It has to be audited by the independent audit group within the plan itself, and it has to be signed off by the general counsel within the plans. So they're taking this very seriously. I know I've sat in the room, I've watched, the sea change within the room from when we started a few months ago. That, at first it was like a biblical experience where they're all talking in tongues. They all had their own, view of the world and can't do this, can't do that. And, to see it come to, one lens has been great. And one of the advantages for me is that, again, the security officer role falls within my organization. The position's been open for about 6 months. So I've been right at the table with customers. And I've heard exactly what they're looking for. I also know what I'd want if I sat in a CFO seat at one of our customers. So it's really easy for me to advocate when I'm sitting with my peer group of the other Blues plans. This is not a time where we cut corners or try to dilute what we're looking to provide for our customers. This is the time we want to provide the highest level of confidence in everything we're doing across the system. Yes?
The SOC 2 accreditation that you talked about that we'll get for this year, will that cover all of those plans? So if I have that on file, I can go to my CFO.
Great question. Right now, it's on the table. It's for the end of 16 for all the plans. Massachusetts will have it for 15. I really wanted 15, to be truthful, but I think most plans felt that the effort to do it is so significant. Certainly, the earlier that you can provide the highest level of assurance, obviously the better. But right now, the way the draft standards that are in final stages right now, it's for the end of 16 for all plans. Now, many of the large plans, just as an aside, I'm not sure if it matters as much, but the large plans, there may be about 14 of them, they represent pretty much 80% of the system. They all will have SOC 2s this year.
So if we have a national plan, should we be getting one from every plan?
Yes.
To meet our own internal requirements?
Mm-hmm.
Oh, okay. We don't currently do that.
No, because one of the questions that I've been asked in more than one session is what I'm doing to evaluate the effectiveness of security controls at Alabama, Tennessee, Florida. And one of the things I do is I look at their SOC 1s, SOC 2s, if they have them, their cyber trust certifications. I look at them to get a comfort level that there isn't anything of an egregious nature that will be a problem for employee data of one of our customers that may be going through those plans. But not everyone has been doing that across the system. So one of the great things about having the uniform standards and uniform third-party assurance is it's very clear to the outside world as to what we're doing.
Does our team work with us at Blue Cross to get those?
Yeah, so twofold. I would say that as much as that would be the right way to do it, I think your CFO or whoever at your organization would look at you and say, you want me to look at 37 SOC 2 reports? So I think that it's incumbent upon us to give you a single view towards the compliance of the system. And so part of an effort here is to get those common standards and then be able to provide a single reporting view into the outcome rather than sending you 37 SOC 2 reports. So I'm very excited, in terms of the SOC 2 element of this, because it is truly the gold standard. I would say that there are very few organizations across the country that have taken on such a rigorous, compliance and view and audit of their business. So it is the right thing to do, but we need to give you a better view and a single view to how we operate as a system.
Yeah, I should have clarified my comment back that, if it's certainly there for the asking if you want it. And I'm always helpful to, give you that single view. Because I am looking at what the other plans are representing out of their control environment as it relates to security.
There's one question about.
Yeah, I just have, what you're describing here I think is very helpful, but I just wanted to raise, I guess, a little bit of a concern or confusion that we had when we were trying to explain what had, happened. So we're contracted through Massachusetts, but we have sites across the U.S. And so then you say, okay, the Anthem breach, well, what states are involved? And, we can pinpoint where our employees might be located. So, for example, Georgia. And so then, people in that area say, okay, well, I'll probably get a letter. And then it was very, there was no rhyme or reason to who got a letter. People are saying, I've only had Blue Cross my whole career. I only see doctors in Georgia. Why didn't I get a letter?
Yeah.
And so then it raised all these questions about, well, what's going on behind the scenes and how can we trust where our information goes?
It's a great question. One of the common activities that is going on as part of this work effort is to have a consistent approach in terms of the way communications are done. So even the fact of information that's shared with the different Blues plans from the breached plan. There were different file formats. Now, the idea is to synchronize this in a way that will accelerate the ability to report out in a consistent, clear way to customers timely as well. But that was part of the feedback that came back, because we knew in our own environment, we're reconciling all these files. There were incompatible formats, there were incomplete data elements on some of the records that came through. Just about every type of data quality challenge that you could imagine, came out of this. So part of the pushback, as the plans were frustrated, customers wanted to know, where they stood, is that, we need to do a better job of the way we organize and send data and communicate out. So, a common approach to just lettuce. So we don't have, a Baskin-Robbins menu.
So I promised 12:30, and I lied, apparently. Very good discussion. Thank you, Ditsis. Thank you, Bill. This was fantastic. Thank you. In terms of data transparency and information sharing, these slides are all available to you, so if you are interested in seeing them, please contact your account executive. We will make them available to you. For anyone, I probably should have covered this at the beginning, that may be freaked out that there are video cameras here. Because of the interest in the content, especially around payment innovation, and from our network executives from sister plans, from our folks internally, we did decide to videotape today. This is not being used for commercial, for marketing, internal purposes only. So don't feel like you have to sign waivers or anything as you're leaving. And we will not use your likeness for any inappropriate purposes. But thanks again for your support. Thanks again for your patience as we went over, and for anyone that had to wait in that traffic outside. Thank you for your persistence as you did finally make it here. Lunches are outside. Please grab one as you go. Next Maac meeting, September 29th, 2015. So please make sure you mark it down. But thank you, everyone. Thank you for your time.